So I'm Jayesh Vyas, Vice President for Cardiometabolic Business of Corona Remedies. From bottom of my heart, I welcome all these dignitaries, our respected course director, Dr. Sanjay Bhadada sir, Dr. Vipin Talwar sir, for the moderator of the first module, Dr. Ameya Joshi, and the faculties for first module, Dr. Arundhati Dasgupta, endocrinologist from Siliguri, Dr. S. Manoj, cardiologist from Chennai, and Dr. Sree Raju, a nephrologist from Hyderabad. At this outset, I'll take only 2 minutes to brief about the progress of Corona Remedies. Today, Corona Remedies is in the top 30 companies of India and with a substantial growth, CAGR growth. We have two big manufacturing units, one at Solan, Himachal Pradesh, that is WHO Geneva approved, and the bigger plant at Ahmedabad, which is also approved by EU GMP now. As you all know, sir, that EU GMP is one of the topmost regulatory authority in manufacturing facilities for pharma industry. At the same time, our plant not only approved by EU GMP, but is also recognized by various world authorities because the entire plant runs on solar system. The water what we use there, that also been purified there itself. So it's a first step towards this taking care of these global warming issues, which are prevailing in the world since many years. When the EU GMP authority approves, which ensures, sir, 100% dose specification, 100% no cross contamination, 100% efficacy, as well as 100% safety. So the plant which is approved by EU GMP, you can definitely trust upon on all the aspects of the health of the patient. The another initiative what we have taken, sir, at Corona Remedies is that we always believe in one world, one quality. That means whatever products are exported and manufactured in our own plant, the same product of the same quality of the same specification are made available for Indian patient as well. If you see many companies, they have the high category of plant, but normally the production which is happening in these plants, they export it. But for Indian patients, they get the job work done from various small organizations. But we believe in one world quality, one world, one quality. That means the product which we are exporting, the same products are available for Indian patients as well, and that too at a very, very affordable rate. So this is what about the background of Corona Remedies. We are committed to promote science as and when we get opportunity. And post ADA, we always do this Deciphering ADA program, that too with Indian patients' perspective. This is the third Deciphering ADA which we are going to start from the few minutes from now. Right, sir? And from next year onwards, our aim is to make this event physical way, not the virtual way. So with this background, I will invite our respected course director, Dr. Sanjay Bhadada. He doesn't require any introduction, but still for my satisfaction, I will say a few words about Dr. Sanjay Bhadada. He is the professor and head of the endocrine department at one of the prestigious institute, PGI Chandigarh. He is the president-elect for RSSDI Punjab chapter. He is very actively involved in teaching as well as research about medical science. He is founder and president secretary of social support group called Aditi, which is Association of Diabetics, that is young, in Tri-City of Chandigarh. He has contributed several chapters in many textbooks, and especially he has contributed many chapters in the 14th edition of Williams textbook of endocrinology. He is mentor for many, many physicians, diabeto and young endocrinologists. So, sir, I hand over the sessions and proceedings to you. Please take up, sir.
Yeah. Thank you, Vyasji, for this opportunity, and my colleagues. Those are the moderator for this today's ADA 2023 and Indian perspective, as well as all the speakers and audience, those are attending this program. So thank you for this opportunity. And like every year, this program is going to be very good because we have very excellent talks, and the galaxy of moderators and the galaxy of speakers are there in next 3 hours and 3 and 4 hours. So without wasting much time, I'll introduce moderator for the first module, and that is Dr. Ameya Joshi. I know Dr. Ameya Joshi since his inception of endocrinology. He's a very dynamic person, and he is consultant in charge endocrinology at Bhakti Vedanta Hospital and Research Institute, Corona Hospital, Mumbai. He's director of Diabetes Endocrine Clinics, Mumbai. He's recipient of many awards, and especially IDF and European Social Endocrinology Young Scholar Grant, and he's secretary of Maharashtra Endocrine Society and the scientific secretary of SCCON 2019. And beyond this, he's actively involved in various activities of Endocrine Society of India. Being president of Endocrine Society of India, I know his caliber, and he's also actively involved in the Indian Society for Bone and Mineral Research, and always have a pleasure to have such a dynamic person like Dr. Ameya Joshi. So I'll hand over the podium to Dr. Ameya Joshi to take the proceedings further. Dr. Ameya, please.
Thank you, sir. It's really an honor to be introduced by Dr. Bhadada, sir. I mean, other than being the president of our endocrine society, sir is author of chapters in Williams' textbook of endocrinology.
Yeah, Ameya, just one small correction for the audience. Not many chapters. I have only one chapter, not many chapters. Many chapters in Williams' textbook is, I don't think anybody can have. So I just one chapter only.
That's a big honor for sir as a person and India as a nation. I think as we move on this interesting symposium for today, which is focusing on Deciphering ADA 2023 in an Indian perspective, let me take the privilege to introduce my colleague and good friend, the versatile Dr. Arundhati Dasgupta. She is Director and Senior Consultant Endocrinologist at Rudraksh Super Specialty Care, Siliguri, Fellow of American College of Cardiology, and has delivered more than 200 talks, published more than 50 articles in national and international journals, and has been honored in more than 10 academic and social events. She is also an author of several chapters, and on a personal note, she is always a treat to listen to. And Dr. Arundhati will be speaking on an interesting topic of are two better than one, or in other words, should you always have a combination therapy in type 2 diabetes, or it's okay for a single molecule to do the trick? So over to you, Dr. Arundhati.
Thank you so much, Dr. Ameya, and thank you for making me a part of this Corona Remedies. So as my friend Dr. Ameya just said, that what I will be talking about today is basically about a debate that was done in the ADA. And this was a very interesting debate where two very, big scientific people from the world, from across the world, they discussed on two things. Like there was Dr. DeFronzo, who was discussing on the combination therapy, who was speaking for the combination therapy. And there was Dr. Nathan, who was speaking against the combination therapy. He spoke for the sequential addition of drugs in the treatment of diabetes. Now, we do know that there has been a concern about which is the best way to go forward. So what Dr. DeFronzo presented was that he said that when you look at the ominous octet, we are aware about the pathophysiology of diabetes being better understood today in terms of 11 pathophysiological pathways. And rather, it has gone up to even more these days, with one or two even coming up even more. But then he says that when you're targeting the ominous octet, how will it do if you're just targeting one pathway? So what he said was that when you are treating a patient, it's just not enough to correct the HbA1c. It's important that you also target the other areas of the pathophysiology so that you prevent the cardiovascular complications, you prevent the renal complications, you prevent the atherosclerotic complications, you prevent, you bring about an overall well-being of the patient rather than just targeting the HbA1c. He also said that when you're doing it in a sequential manner, which was initially done, you add a drug, doesn't act, and then you add on something else, and then that doesn't act, you add on the third molecule. That is a pathway towards the treatment to fail. He said that this is not the correct way to be, because we have seen across many studies that this leads to a bad metabolic memory. This leads to a situation where most of the people, and he cited the UK PDS, he said that here the molecules were added in a sequential manner, and almost 65% of the people who were a part of the treatment of UK PDS went on to insulin by 15 years. And this was a result of them not being treated very aggressively from the word go. He also cited two other studies that have been done, one which was done under him, which is known as the VIC study, wherein the combination therapy was compared to the sequential therapy, and better results were obtained with the combination therapy. And he said that his idea of a combination therapy includes a GLP-1 receptor agonist, an SGLT2 inhibitor, and pioglitazone, as he places it. And he also spoke for the other combinations, in sync with the targeting of the different areas of the pathophysiology. Now, to combat this, what Dr. Nathan said was that he had three points to say. First of all, he said that if you're adding a combination from the very word go, number one, you do not know which molecule is giving you what kind of benefit. So you do not understand one molecule in its total perspective for this particular patient. Number two, he said that the side effects come in together and you do not know to which to attribute. So you have, three drugs put in together and somebody has nausea and vomiting or something else, and you don't really know which drug is doing it. Thirdly, he said that it is costly to put in a combination, because the difference in the cost when you're putting in a combination from the very beginning as compared to a sequential therapy is marked. So these were his points. These were the points that were raised by the two great minds, Franz and Nathan. If we try to understand this concept in our own perspective, from the perspective of our Indian patients. Now, when we look at the data, we understand today that our patients are slightly different from the patients of the West. We have diabetes, which is coming in earlier. We have cardiovascular complications coming in earlier. We have beta cell failure, trending in earlier in our patients. We also are conscious about the difference in the phenotype of our patients. Metabolic memory has been very strongly understood over the years. And today, I think the vast majority of our doctors in India and across the world agree that it is the concept of stepping up therapy one by one does lead to a series of years wherein you are not keeping the patient under control, and that has led to a number of complications subsequently. So majority of the patients, the doctors who are treating patients in India, there has been a meta-analysis of what they think, and there have been questionnaires that have been put forward to understand the perspective of doctors, and most of the doctors have actually agreed that in our setting, looking at combination therapy is probably a better step forward because of all the data that we have together. Combination therapy, we have seen the VERIFY trial, wherein we've seen the benefit of combination therapy, wherein the two molecules added together vis-a-vis them being added in a sequential combination did result in better control in the combination therapy group. So given the data that we have together, given the understanding of our patients with diabetes, given their differences and their tendency to have a beta cell failure very soon, I think from my own perspective, after having heard both these people, debate on these two issues, my personal opinion, and that the opinion of a lot of my colleagues, is also that probably in our context, the combination therapy stands better. Now, which two combinations you're going to choose, or which three combinations you're going to choose, you'll have to basically look at the pathophysiology and choose a combination that targets most of the pathways of the pathophysiology, so that you're not only giving the patient a benefit of the HbA1c reduction, but you're also looking at giving them benefits in terms of cardiovascular protection, in terms of renal protection, in terms of protection of, from heart failure, in terms of protection from the other atherosclerotic complications. So all these things put together, I think today where we stand, we will definitely, most of us, I would say, would definitely favor combination therapy because that, as we know, the Defranzo's theory that has been put forward is basically attacking the diabetes from the very word go and not allowing it to seed its destruction in the various organs before we kind of attack it. So that was it. I think this has been the basic discussion. We do agree. I mean, of course, we must agree that the data with the studies that have looked into the combination therapy in comparison to the sequential therapy is limited to small number of studies, because most of the comparisons between the combination therapy has been with the monotherapy. They've not been with sequential therapy. So we do have one or two studies wherein, like the VICT, wherein we have seen a comparison with the combination and the sequential, but data indeed is small. It's limited to small number of patients. The duration of the studies have also not been very long. So these are the drawbacks when we are talking in favor of combination therapy. But then again, when we look at what we have achieved with all our knowledge, we do realize that majority of our patients, 50% of our patients still have an HbA1c of more than 7%, and 25% of our patients have HbA1c of more than 8%. So this has been more seen with the the sequential therapy, and that brings us to to this point wherein we need to decide whether we go aggressive from the very word go, or whether we give it a little bit of time, whether there's a clinical inertia in initiating a combination therapy. My vote would be for a combination therapy, certainly. Of course, understanding where the patient stands, what combination you would want to put in. Though Defranzo did say about taking away metformin from the very initial combination therapy, I think a lot of us might not agree with that. We would rather keep in metformin and add on other molecules, maybe an SGLT2 inhibitor or an GLP-1 receptor agonist, which would act at the other areas of the pathophysiology. So that's that. Yeah, Dr. Ameya.
Thank you, Dr. Arundhati. I must say that was fluent and fantastic. I must also say that whenever you think of India and where it has done exceedingly well only as a combination, it's a field of tennis. We only won doubles Grand Slams. We never won the single Grand Slam. So maybe in diabetes also, it's unique that we have a little different, what I can say, type of diabetes, maybe poor beta cell, poor incretin, and more cardiovascular risk. And that's how maybe I concur with you that an early combination is justified. However, an interesting perspective is that a good number of our diabetic patients have cardiovascular disease at the beginning. Some of them have a raised NT-proBNP. Some realize that they are diagnosed diabetic because they are also found that they come with some chest pain and the diabetes is diagnosed. So I think we also need to give them the benefit of best possible combination therapy. And maybe for somebody with diabetes, the best possible combination therapy is SGLT2 plus GLP-1 receptor agonist. And to take us through that, I would like to invite our next speaker, who is Dr. S. Manoj. Sir is a cardiologist and interventionist at Kaveri Hospital, Chennai, with more than 19,000 cardiac diagnostic and therapeutic procedures to his credit, with more than 30 academic and social event honors, with 20 articles in national and international journals. Sir is a clinical research associate and co-investigator of several clinical trials. I would also request Dr. Arundhati to stay back for the panel discussion, and it's over to you, Dr. Manoj.
Thank you for the invite for this great meeting on the Deciphering ADA 2023. So with your permission, I think I would share some of the relevant data on the PowerPoint, which is against the extempore presentation. But I thought it is very relevant to understand some of the important clinical evidence that has accumulated over the period of last decade or so on the topic of on the space of SGLT2 and the GLP receptor agonist. So the focus will be basically on the SGLT2 and GLP-1 receptor agonist. For long, we have understood that we have been focusing on glycemic control alone, but subsequently during the course of analysis and our own approaches, we found that the patients with diabetes have had significant cardiovascular morbidity, and therefore they also have a clustering of various cardiovascular risk factors. And this puts them, along with this diabetes as a significant comorbidity, at a premature risk of cardiovascular disease, cardiovascular mortality, and also various peripheral arterial disease and heart failure. We come to know in the last 7 years or so that peripheral arterial disease followed by heart failure is a significant initial manifestation of the cardiovascular disease occurrence in diabetic population, and therefore various studies have addressed whether one of these therapies addressing the glycemic control would also confer a significant enhancement of the risk, or is it safe for the patients who are already having a background of cardiovascular disease risk. So this is a meta-analysis of the various SGLT2 trials, which was published in The Lancet in 2019, and it showed that the EMPA-REG, Canvas, Declare, TIMI, Credence, and Vertis CV all consistently showed in a pooled estimate that the trials or the agents, the SGLT2, significantly reduce the first occurrence of the major adverse cardiovascular events. And that was very, very consistent across all the diabetics who have a high cardiovascular risk subject. Now, if you look at the heart failure hospitalization, the consistency of benefit was much significant. And you will see that almost 32% relative risk reduction from use of SGLT2 in diabetics in reducing the heart failure hospitalization, which is one of the most important determinant of the survival of a patient with a significant cardiac morbidity in the form of a heart failure. Now, if you split up all these trial manifestation or the trial endpoints, you would see that the EMPA-REG, Canvas, Declare, TIMI, and Vertis, all these agents of SGLT2 and the trials, one thing was just consistent was a significant reduction in the heart failure hospitalization, which is seen here to the extent of 30 to 35%. But what was not consistent was on the mortality of the cardiovascular death, whereas empagliflozin reduced the mortality, cardiovascular mortality. The other SGLT2 did not bring down the cardiovascular mortality in patients who have diabetes with established cardiovascular disease and all or the risk factors. The major adverse cardiac events did come down with empagliflozin and also the canagliflozin. So subsequently, the trials addressing the SGLT2 in those with or without diabetes, but having baseline heart failure, or who had had an episode of decompensated heart failure or a de novo heart failure, were randomized into placebo versus SGLT2. In DAPA-HF, it was dapagliflozin, and EMPEROR reduced, it was empagliflozin, and patients were to have a ejection fraction of less than 40%. And again, both these trials consistently showed there was a remarkable benefit to the extent of 25 to 26% relative risk reduction of the heart failure hospitalization and also cardiovascular morbidity, and which was consistent with the use of SGLT2, which is very safe and proven to be very effective in reducing the hospitalization cardiovascular morbidity if a diabetic subject has a heart failure. So the SOLOIST trial is a recent trial with sotagliflozin, which again consistently showed a significant reduction in the cardiovascular death, heart failure hospitalization, and urgent heart failure visits. And this is to the extent of, again, 33%. So it was much more effective. The sotagliflozin also has a dual benefit on the SGLT1 inhibition, and therefore we are hoping for more trials to come and show that the sotagliflozin, with an additional benefit of SGLT2 as well as SGLT1 inhibition, would confer a significant benefit to give us a choice of which among the SGLT2 would be a preferred drug for the heart failure reduction and cardiovascular mortality reduction in diabetic patients who have a heart failure. Now, if you look at the cardiovascular outcome of all the GLP receptor agonist, we would look at the LEADERS trial, the dulaglutide REWIND and SUSTAIN, and the oral semaglutide trial PIONEER. And all these distinctly showed the major adverse cardiovascular events were consistently reduced to the extent of 20 to 23%. So, whereas a semaglutide brought down by 26%. The oral semaglutide on the Pioneer also showed a 21% reduction in the cardiovascular outcome or major adverse cardiovascular events. And this was particularly driven by myocardial infarction and stroke reduction. Now, the major adverse cardiac events with the GLP-1 receptor agonist trials, all put together with the available trials, showed a consistent pooled benefit of 22% relative risk reduction of the major adverse cardiovascular events with the use of the GLP receptor in patients with diabetes and also significant underlying comorbidities with the cardiacs. So the SUSTAIN 6 is the semaglutide also showed that distinct primary outcome, non-fatal myocardial infarction, and also the non-fatal stroke was significantly reduced, whereas it did not affect the mortality from cardiovascular disease. So the major adverse cardiovascular events, non-fatal myocardial infarction, and stroke, particularly stroke, non-fatal stroke was significantly reduced. So they showed that there was an additional benefit of GLP receptor agonist on the neuroprotective effects in cerebral atherosclerosis and also reducing possibly vascular dementia or even sometimes looking at the extended benefit in the Alzheimer's disease. So the non-fatal stroke, if you see among all the pooled analysis, overall the use of a GLP receptor agonist therapy brings down the relative risk reduction by almost 26%, 16% with the use of GLP in patients who are diabetic. So there was a significant reduction in the stroke reduction itself. Now, looking at the SGLT2 and heart failure, which was already discussed, I would go into a little more in detail about the continued use of SGLT2 in sugar DM heart failure, as well as the Empire heart failure, which looked at some of the remodeling effects. So it does confer significant benefit in the form of remodeling of the left ventricle in various parameters of the end-diastolic volume, end-diastolic systolic index, the left atrial volume and ejection fraction, which over a period of time significantly improves the cardiac performance. Now, this is the DAPA-HF and Emperor reduce, which was consistently showed a benefit of cardiovascular death and heart failure reduction in the heart failure hospitalization, and also the mortality reduction with the cardiovascular death and all-cause mortality was also reduced consistently across both the groups of dapagliflozin and empagliflozin. Now, the SOLOIST trial again showed a 33% reduction of a combined heart failure and heart failure hospitalization and cardiovascular death. And it was consistent across all the groups, subgroups of patients who had higher heart failure in the regardless of the ejection fraction, regardless of the diabetic and the gender differences, and also the age and eGFR. Now, the DELIVER and the Emperor Preserve looked at the usefulness of SGLT2 in people with the heart failure with preserved ejection fraction, by which I mean that ejection fraction is above the 50% mark and or 45 to 50% mark. And again, among the diabetics as well as the non-diabetics with the HFpEF preserved ejection fraction heart failure, there was a consistent benefit by 20% in the heart failure hospitalization and 18% reduction in the cardiovascular death, which was also seen with the empagliflozin significantly. So there was a consistency in that. Now, finally, to conclude, I would say the SGLT2s are very, very important drugs in the management of heart failure, as well as in the management of diabetics with cardiovascular risk factors, and also diabetics with heart failure at baseline or without heart failure at baseline. And it significantly enhances the outcome in both patients with reduced ejection fraction and preserved ejection fraction. With regard to the preserved ejection fraction, we did not have any significant molecule modifying the outcome in patients with HFpEF till now. And this is the only considered molecule which is found to have a favorable impact on the survival as well as the hospitalization reduction with the SGLT2 use in patients with the heart failure. And that is regardless of whether patient is a diabetic or not diabetic. However, we certainly do not know the exact mechanism by which the SGLT2 confers a significant cardiovascular favorable benefits, which are not clear at this point of time as we discuss this. The dual inhibition, as I said, with the sotagliflozin with the SGLT1 inhibition, and SGLT2 inhibition is a very promising approach and needs to be seen in the subsequent years. Now, all this put together, the ADA standards of medical care for diabetes for the clinicians involved in the diabetic care distinctly have to look at whether the diabetic patient has an established cardiovascular disease, or they also have a high cardiovascular risk factors, or they have a high heart failure or CKD. The CKD aspect would be discussed by the following speaker by the nephrologist specialist. But I would look at if the individual with the diabetes has a established cardiovascular disease, or there are indicators of a high cardiovascular risk in that subject with diabetes, you have to initiate a GLP-1 receptor agonist and also SGLT2. So if the glycemic targets are above the goal, you may have to optimize the doses of the GLP-1 receptor agonist and also add other intensification of the lifestyle therapies and also patient-centered treatment factors and the dietary factors, and also consider the DPP-4 inhibitions. Now, if the diabetic patient has a baseline history of heart failure, then SGLT2 becomes the important drug to be added upfront. So these are the important considerations. With this, I would leave it for the open discussion. Thank you for the attention.
Yeah, thank you, Dr. Manoj. I think that was really interesting because at least for those who are vulnerable for organ damage, the diabetes treatment has changed from glucose stabilization to organ protection. And that has happened mainly for those with cardiovascular disease or those with CKD. The extent on the horizon is what we call it as a metabolically associated liver disease, for which also organ-specific treatment strategies are being devised or on the horizon. So as we move on, let us go from glucocentric to cardiocentric to nephro perspective. And other than cardiovascular disease, the chronic kidney disease is also something that affects the life of a diabetic patient. One of the important challenges in CKD is a high vulnerability to have a ischemic heart disease and cardiac failure. Also, diabetic kidney disease itself is a spectrum. And to discuss about diabetic kidney disease in type 1 and type 2 diabetes, is it the same disease? I would like to welcome Dr. Sree Raju, who has more than 100 publications and 12 chapters to his credit, received 7 Best Paper Awards. He is one of the principal investigators of CKD Task Force by ICMR, has several national and international journal publications to his credit. He is an editorial board member of several journals and associate editor of Indian Journal of Nephrology and Indian Journal of Transplantation Frontiers. He has served as the member of Governing Council of Indian Society of Nephrology and many other societies, organizing secretary for INCON and ISOCON, received the Meritorious University Teacher Award by Telangana government, and delivered more than 200 public talks related to health on various TV channels. It's an honor to welcome you, sir. It's over to you.
So good morning, everybody, and thank you very much for the kind introduction and the respected colleagues and dear friends. Today morning being a Sunday and it's raining very heavily outside, and it is appropriate to have a Zoom meeting only rather than anything else. And good that they did not organize any physical meeting elsewhere. And type 2 diabetes or type 1 diabetes, both of them are very important in nephrology practice. As the previous speakers also stated that these people are at risk of developing the metabolic complications and coronary artery disease as well as the chronic kidney disease. And 50% of the patients with the type 2 diabetes and almost nearly 30% of the patients with the type 1 diabetes, they develop kidney disease. But is it the same? And in fact, this particular topic, when it is given to me, I really liked it actually, because we have been thinking in terms of the differences between the two for the past few years. And as such, I must confess that right from the beginning of our career as a nephrologist for the past 24 years, 25 years nearly now, And that we have been seeing a lot of type 2 diabetes with the kidney disease, but never bothered much about the type 1 diabetes. And once in a while, we were getting 1 or 2 cases of type 1 diabetes leading to kidney disease. But for the past a decade, we have been seeing a lot of patients with the type 1 diabetes, which have violated the basic principles and also the clinical course descriptions given by the ancestors in nephrology practice, something like a Mogensen. He's not a nephrologist basically, but still for the past 40, 50 years, we have been talking about Mogensen's classification, how the clinical course of type 1 diabetes. And as such, the type 1 diabetes was predominant, and most of the clinical course studies and drug trials, everything discussed much about the role of these drugs in type 1 diabetes. Then for the past 3 decades, slowly after the renal trial and IDH trial, slowly we started getting more of type 2 diabetes. Now we have a predominantly in our nephrology practice, almost 90% of the diabetic patients with the kidney disease are type 2 diabetic, and 10% of them are type 1 diabetic, but still that number is increasing. And what is happening in the age-wise, if you really look at the age of onset of the disease, and the Mogensen's classification stated that nearly young children who develop type 1 diabetes for the next 20-25 years, it will take for them to get into kidney failure. And the type 2 diabetes doesn't follow this kind of a clinical course at all. And the type 1 diabetic patients, they take nearly 15 years to get some proteinuria, 20 years to develop some renal dysfunction, and by almost 20-25 years, they get into CKD and ESRD. Type 2 diabetics, on the contrary, they come to us with a classical clear-cut case of renal dysfunction, or they come with a proteinuria. Sometimes it can be nephrotic syndrome. And very interesting is that sometimes they come to us with a renal disease. They never happen to have any kind of a kidney diabetes at all. But when we do a kidney biopsy and we see the classical features of diabetic nephropathy, and we find for the first time that they are diabetics also, which was never treated, never diagnosed also. But it's very common that the type 2 diabetes has got no clinical manifestations unless they get into some problem. So that is the one. And here, and the age of onset, we were seeing a lot of youngsters and also the patients at around 15 to 18 years also with the type 1 diabetes, getting into nearly 3 to 5 years after getting onset of type 1 diabetes, getting into renal disease. This is a gross violation of what has been observed for the past several decades back by Mogensen et al. And now the type 2 diabetes also doesn't follow any clinical course. To start with, they have renal disease, and the progression also very, very rapid. Those patients who are getting a diabetes in 20s and 30s, and immediately within 5 to 7 years, they are getting into kidney disease also. And when we take the patient with the kidney disease, when they take the history, the mean average age of onset of disease and the duration of type 2 diabetes is just 3 to 5 years and not more than that. And moreover, they are very young patients. When we were students, we were taught that more than 45 years or 50 years is the type 2 diabetes. And by the time they get renal failure, they are in 60s and 70s. Now, early onset of disease and also the early and rapid progression of the disease that has led to the rapid deterioration of the kidney function leading to ESRD very early and fast. So that's the one. The second one, the indication for biopsy. So are we doing kidney biopsy for each and every type 1 and type 2 diabetic? No, we have been doing it actually. I must confess that we have the largest series of patients having kidney biopsies of both type 2 as well as the type 1, almost nearly 2,000 approximately the patients for the past nearly 10 years. And we have a protocol for kidney biopsy, and we found that there's no correlation between the clinical course versus the histopathological evaluation, both the groups. But interesting aspect of this is that those so-called definition, all of us know that is a proteinuria and fall in GFR. But a good number of these patients do not have any kind of proteinuria, both type 1 as well as the type 2 diabetic. But the non-proteinuric type 1 diabetic will have a very rapid course, and they come to us with a frank end-stage renal disease within a few months only. Whereas the non-proteinuric type 2 diabetics will have a sustained course, and they stay for a very long time for the conservative treatment, and they maintain renal function fairly well for a long time and before they deteriorate. If they deteriorate fast in a very late stage, it will be very difficult. Previously, once they get into proteinuria, it was said that they never get a remission at all. But it is happening now, thanks to the newer therapies, both the insulin as well as the newer drug therapies, where the proteinuria, especially when it is in the microalbumin stage, that can be reversed back, and they can go back to normal albuminic condition. But it's not, and it can happen even in the lower state of proteinuric conditions also, but not in a nephrotic range of proteinuria, or not in a higher grades of more than 2 grams proteinuria per day. But those with more than 2 grams per day, and usually they deteriorate fast. Patients with a nephrotic syndrome, also they deteriorate fast. That shows that the more the proteinuria, more the deterioration and the faster and quicker deterioration in the kidney function. And also, interesting aspect in type 1 diabetic is that the patients with the normoalbuminuria are at more risk of coronary artery disease. You know that microalbumin or proteinuria is a surrogate marker of risk of coronary artery disease. But here, without a proteinuria also, these people are getting into more coronary artery disease incidence. And type 2 diabetic patients, they have you know that all of them are at risk of coronary artery disease. Most common cause of mortality in our group of people with the type 1 and type 2 diabetes is the coronary artery disease. That's why right from the beginning, we try to prevent the disease and the clinical course also in them. And another interesting aspect is that non-diabetic renal diseases. When we started doing kidney biopsy, we found that good number of them are not diabetic kidney disease. They are having non-diabetic renal disease. Almost 30 to 40% of them are having a non-diabetic renal disease, something like a membranous nephropathy, IgA nephropathy, FSGS, some of the acute interstitial nephritis, even crescentic. And recently we started seeing some of the very rare entities called fibrillary glomerular nephropathies, which are genetically mediated, and very rare disorders also we started seeing them. That's why the indications for biopsy in a diabetic patients are very, very important. And when we do biopsy, and what we are finding is also equally important. Not only that, some classical indications like a presence of nephrotic range of proteinuria, presence of rapid increase in the amount of proteinuria, presence of recent deterioration in the kidney function, and presence of systemic disorder like a sarcoidosis or amyloidosis suspicion, or having an active urine sediment with a microscopic hematuria, proteinuria, and active urine sediment with RBC cast and etc. You have a classical indication for kidney biopsy. But when we see these kind of indications, when we do a biopsy, we are seeing varieties and varieties of cases which change the clinical course totally. That shows that diabetic patient with a kidney disease doesn't mean that every time it is equal to diabetic kidney disease alone. There can be some other entity that should be evaluated thoroughly, and it can totally change with the treatment, a clinical course, which probably change the clinical course of the entire disease. And probably it can become better also if you treat an early and appropriate intervention done properly. So these are the things. And coming to the therapy aspect of it, and therapy is very important, that insulin. And I heard that some of the, probably you can learn from endocrinologists that some of the patients are getting treatment even for other drug therapies also other than insulin for the type 1 diabetic. The type 2 diabetes, and as my previous speaker, cardiologist, also spoke very well about SGLT2 inhibition. And I'm one of the principal investigators of Credence trial. And we found that it's very important that these kind of drugs should be instituted to the patient very early in the clinical course so that they can get a benefit also for a very, very long time. And non-steroidal mineralocortical receptor antagonist, something like a finerenone, has come into picture. And it is helpful not only in a diabetic, but also in non-diabetic kidney disease also. When we do a biopsy and when we find non-diabetic kidney disease also in a diabetic, we continue with the drug therapy for a long time.
Internet is down for the last several days.
So finerenone is also found to be a very good molecule, and it has made an inroads into the therapeutic armamentarium of type 1 and type 2 diabetes. And finerenone can be given fairly well. It can have function even in type 1 diabetics also. And the studies are going on where these kind of molecules being tried in type 1 diabetes and effect on clinical course. So, and then the complications. The complication wise, the retinopathy, nephropathy, you know that they go hand in hand, concordance rate of more than 90%. Type 1 diabetic patients we found in our practice is that very good number of the patients will get retinopathy and they deteriorate very, very fast, unfortunately. But whereas type 2 diabetic, retinopathy will be stable for a very long time, but they get into coronary artery disease complications as well as the peripheral artery disease complications. So these are the differences which we found in type 1 and type 2 diabetes. And coming to transplantation and dialysis and transplantation, which is very important. And unfortunately, type 1 diabetic patients, they don't sustain well on dialysis. They deteriorate very, very fast. And say, for example, if I have 100 type 1 diabetic patients, almost nearly 80 to 90% of them will die in less than 1 year after the initiation of the dialysis. With the type 2 diabetes, they sustain very well. And we can go ahead with the transplantation also for them. And the transplantation, we have done good number of type 2 diabetes. And of our nearly 1,500 transplantations for the past 2.5 decades. And we have around 5 to 7 type 1 diabetic patients undergoing only kidney transplantation without pancreatic transplantation. We don't have a pancreatic transplantation facility in our institute and across. And we have done recently also for the past 4 years, we have done 4 patients type 1 diabetes with a cadaver renal transplantation. All of them are doing very well, interestingly, at least for the past more than 1 to 2 years of follow-up. They're doing very well. Type 2 diabetics, they get into complications of coronary artery disease. As I repeatedly utter that whatever said and done, these patients are at maximum risk of developing ischemic events and coronary events and strokes, and we should be very, very careful about treating these patients. If at all we plan for transplantation, we see that both the type 1 and type 2 diabetes patients should be screened properly, thoroughly for occult episodes of coronary artery disease, and aggressive management should be done before transplantation itself, so that they can do very well both on dialysis and transplantation, because longevity depends on the coronary artery disease rather than the management of diabetes alone. As they advance in renal failure, mostly the diabetes gets controlled without any drug therapy also. At least 80% of our patients on dialysis, they do not really require any drug therapy or insulin therapy as such for the control of their diabetes, because by the time they get CKD and ESRD, the diabetes gets controlled automatically. And unfortunately, the glycoside, hemoglobin A1C, and other markers are not good markers to predict the changes are probably the control of diabetes in them. So we don't go by any of these molecules, but we gradually follow them up. And over a period of time, we see that they require dialysis and transplantation, and they do well on after transplantation also. We have another entity which is probably not so known to many people outside, is that the post-transplant diabetes, and their management is exclusively done by us and also our endocrinologist locally. And their clinical course also goes very interestingly like type 2 diabetic. They deteriorate. We have few patients who had type 2 transplantation followed by diabetes, and they deteriorated very fast. And they also developed a classical diabetic nephropathy changes in the kidney biopsy. So what we found ultimately over a period of time is that age of onset of type 1 diabetes and type 2 diabetes has changed, and their early manifestations and the clinical course has changed. There's a rapid deterioration despite having newer drug therapies, and we need to see the effect of these two drug therapies like finerenone and SGLT2 inhibition over a period of time. And also, the management involves multi-pronged approach by number of physicians and the surgeons being involved in that, and both the complications can be managed very well if we start very early in the clinical course, if we start them. So thank you, and probably I'm very happy to take up the questions rather than giving an extempore talk like that, because even I don't know what and how much is appropriate to speak now. Thank you.
Yeah, thank you, Dr. Raju, for, I would say, again, a very fluent and wonderful deliberation. I extend my deepest gratitudes to Coroner Remedies for inviting all of us. Also, I must say that somebody inadvertently, something we heard about the rains and the virtual and physical meetings. I think in Mumbai, at least, we are literally flooded and sometimes sailing, sometimes walking. Yes, or a cycle.
Sailing and swimming.
Yes.
Sailing and swimming.
Somehow managing. And yes, sir. So let us move on and have some interesting thoughts as from our speakers. And I would maybe like to start with Dr. Raju only. And maybe take the last part of his talk where he was talking about the change in age of onset of diabetes as well as its complications. I would say type 1 diabetes, we have seen it occur more frequently, maybe because concurring with more incidence of autoimmune disorders. But as regards type 2 diabetes, sir, typically we are a decade early. Have you also noted that post-COVID, we are seeing it even come a bit more early? And what is your experience about age at which it occurs and the complications?
For the past few decades, we have been seeing that the age of onset of diabetes and its complications are occurring very early than the one. And I can say that being in a teaching institution and that to continuously at one place, and for the past more than 2 decades, I could notice that I have treated the grandparents, grandfathers, and I've treated the fathers, and also now I'm treating the grandson also now. So the third generation, I started seeing them, and I could really tell them also that you are going to get a diabetes. And their grandchildren have come to me already with the reports and they are being under treatment also. That shows that the type 2 diabetes, the age of onset has actually preceding and well in advance that early in 20s and 30s, like contrary to the common belief long back when we were students that it's only 40s, 50s and above. And initially we have seen such kind of people also. Even now we have a lot of people who are maintaining very well for the past 20, 30 years. Interesting is that those who maintain well, they maintain very well without any complications. We have patients in 70s and 80s without any single complication. They just like that come. But patients who, young patients are coming very fast and quick with the complications, and especially nephropathy and retinopathy and cardiovascular. So we need to probably address this particular rash issue, because the longevity over a period of time, next 2 to 3 decades, would come down significantly from a mean of 67, 68 to 50s if we don't treat aggressively the type 2 diabetes and the complications. Age has definitely is coming up very early.
Yeah. Moving on to Dr. Arundhati, I think I have an interesting question for you. Nowadays, diabetes is coming early and rampant. I think, as Sir said, we have families coming to us with diabetes. But when someone comes to you with a lot of, I would say, hue and cry and social media, what I can say, awareness about reversal of diabetes, a person A coming to you with an HbA1c of 7.5 and saying that, madam, okay, I have came to you, but I want to reverse the whole thing. What is your advice to that particular person? Start medication and we can always stop, or maybe wait and watch and then we can discuss after 3 months.
So thank you, Dr. Ameya. That's a very interesting question and a very pertinent question, because these days, as you said, a lot of our people are social media read, and then they come and talk about reversibility. So I often get such patients, and what I generally do is try to explain to them about the entire concept about reversibility. I tell them that, reversibility, it's not that it doesn't happen, but it happens in a very small section of people who've had a very bad lifestyle, who can make major changes, who can, remain on very limited amount of food for a substantial amount of time, can go for aggressive lifestyle changes, exercise, which is something that people do initially when they're diagnosed as diabetics, but they do not carry on. We also try to explain to them that we do not call it reversibility exactly. We would rather call it a controlling or putting it in check, wherein you do not need medications for a considerable amount of time. But then you have to understand that the entire concept of reversibility, whatever studies have been done with reversibility, dealt with patients who were put on very limited amount of calories. Restricting the calories for your patients to 800 or 900 kilocalories is very difficult on a day. It's okay for a study, it's okay for a limited period of time, but continuing that over a substantial period of time can be very difficult. So at 7.5, maybe I would not start off immediately with therapy. I would give the patient some time with lifestyle measures, with diet and exercise. But if the same patient came to me with, say, 8 or 8.5 and spoke about reversibility, I would not take a chance there. I would start off with therapy, definitely, and at the same time advocate very strongly for lifestyle changes. Once having said that, Dr. Ameya, as you would realize, the first 3 months everybody is very active. Once things fall in place, it's a gradual thing, and then sometimes they'll come back to you. Initial HbA1c has come down to 6.5, then after 3 months when they come back to it's again gone up to 8, 8.5, because they've been casual about things. So what needs to be understood is that this is going to stay. You might keep it in control, you might put it back, you can push it back, but it's not going away, because the basic pathophysiology that triggered it is not going away. So it's only when you make substantial changes. Somebody comes with a BMI of 30, 31, and I advise him for weight loss and he goes very aggressive. That is where maybe I would be able to see some amount of reversibility. But somebody who's already maintaining a moderate good lifestyle, is already not eating a lot, is not splurging, where are the changes that I can make where I can reverse the diabetes? So that is what you would need to explain to the patient, where things stand, and try to, kind of bring down the hype about reversibility. At the same time, understand that reversibility does happen in a small section of people, where you can continue to make these continuous changes in the lifestyle.
Yeah, I think I practically feel that I feel more comfortable to tell them that, okay, you want to reverse diabetes, I totally concur with you. I can tell you how to do it. You have to start with it, but don't be without medication. Start something. we can always rediscuss. If you're done well at 3 months, the chance of which is less than 20%, and maybe at 6 months, less than 10%, maybe I'm very open to stop them and take it as your credit. That's what as I have been following, because many of our patients just,
What we do with insulin, you kind of persuade them to start off and I'll stop it eventually. But then you know that in most patients you cannot. Yeah, but tell them about it definitely. Yes.
Thank you for, I would say, heartfelt deliberation. I think something that we have been facing day in and day out. I think I would also now move on to Dr. Manoj sir, and I think I sort of liked his presentation about the cardioprotective treatments and discussing about SGLT2 inhibitors and GLP-1 receptor agonists in cardiovascular disease. My question to sir is very specific, that currently what we have as a most accepted GLP-1 receptor agonist in our OPD, which is oral semaglutide. I mean, if I give 3-4 options to the patient that, okay, injectable liraglutide, then some of them are little fancy. They will get indented that Wegovy, or some of them will opt for dulaglutide. But if you want cardio protection and GLP-1 receptor agonists, and you have a choice, which will you prefer?
Well, I think it's a practical question. Personally, I've not used much of GLP-1 receptor agonist because I would get involved, partner with my diabetologist colleague to give us understanding. From that, what I understood is currently the experience is more with the liraglutide injection because it came early in the course of our armamentarium. Subsequently, now in the last 1 year or so, you have oral semaglutide, and the adoption of GLP receptor agonist has significantly been enhanced after the oral semaglutide has been made available. But distinctly, we all know that these are all long-term or rather lifetime therapies, at least during the rest of the patient's life. And the cost of the therapy, if you see the comparative chart even issued by the ADA, one of the color tag for the GLP-1 receptor agonist is about the cost of the therapy, which is tagged red. So worldwide and globally also, even in reimbursable societies, the adoption and uptake of GLP-1 receptor agonists, despite their significant robust evidence clinically showing reduction in the stroke as well as cardiovascular morbidity and also renal protection in particularly, has been very, very slow, and that is also translated into our practice also. So I don't see much of a GLP-1 receptor agonist being prescribed even in many of the diabetologists' perspectives, and many of the diabetic centers in Chennai, I would say, when patients come to us because they also have a cardiovascular morbidity, I see around less than 5% of them get GLP-1 receptor agonists. So among that, of course, between the GLP-1 receptor, I would say the oral semaglutide has been more frequently prescribed in the last 1.5 years or so. Previously, there were a select prescription for GLP-1 injectables like liraglutide. In fact, I revert back to them, stating a letter with the current evidence speaking in favor of GLP-1 receptors. Could you consider introducing these therapies for the patient's long-term cardiovascular outcome benefits to the diabetologist, and they possibly discuss with me and then take a decision in consensus. However, the patients every time do come back to us and say it's a very expensive therapy and cannot be sustainable, and that way it has to be pocket friendly and patient friendly as well, and that would make a clinical impact on how the patients would adopt, and also the clinicians would adopt these important therapies in their practice guidelines.
Yeah, I think, Dr. Manoj, that's very, very, I really appreciate that, because when two doctors tell a patient, because an endocrinologist discusses this aspect, then the person has his reservations, he will come back, ask, okay, but when cardio and endo both have endorsed this, the uptake of GLP-1 receptor agonists is much better. I'll also ask the same question to Dr. Arundhati in a little different way. Now that we all agree that most of them prefer oral semaglutide over injectable GLP-1 receptor agonists, But we don't, do you give it with the same conviction that it is going to be cardio protective, or you would like to wait for some more data? Because I think semaglutide in the body is semaglutide, whether you give it whichever possible way.
With the data that is available today, you are giving it with a lot of conviction, because it will be difficult to prescribe a molecule that is that expensive unless you are convinced about its efficacy in terms of not only HbA1c reduction, weight reduction, but also an extra added benefit in terms of cardiovascular benefit. But having said that, we must also take into account what was said by the previous speaker, that we have more of evidence with some of the other molecules, with the once weekly liraglutide and others, which you have kind of used it in so many patients that you're more convinced about what has been happening. Yes, but Dr. Ameya, I would say that I do also have a significant amount of people who do not want to take the oral therapy. For them, it's a hassle, like, taking it, waiting for half an hour. They do not want to go through all of that, particularly if they're also on, LT4. So it's like half an hour wait and then another half an hour wait. When I tell them this, a lot of them do choose the once weekly GLP-1 receptor agonists also. Conviction is there, but I think we'll need some more time to see the results in the real world before we are, as much convinced as we have been with the real world data from some of the others that have stayed for some time.
Yeah. I have a question for Dr. Raju, that how convinced he is, or how comfortable he is using an SGLT2 inhibitor in diabetic kidney disease patient with type 1 diabetes.
Recent literature also shows that, but we have done a study literature, the Credence trial and other trials. This molecule we have been using as a part of the drug therapy. For some of them, maybe placebo also, we don't know. But in the Credence trial, we found that it is very, very important for these drug therapies to be given very early in the clinical course. And as such, the routine convention of insulin only in type 1 diabetic, and probably we are supposed to give, especially when I was reading the literature, I found that some of these patients would get benefited out of SGLT2 inhibitors. And as I stated in my lecture, that even mRNA antagonists also can be given to them, and safely and comfortably. But I don't have much experience. I never treated any type 1 diabetic patient with SGLT2 inhibition so far. I've treated even post-transplant, but not type 1 diabetics, because I believe only in the insulin. And I consider that insulin is a very good molecule and a very good therapy for type 1 diabetics. And even type 2 diabetics also, I give a small dose of insulin, and everything else is an extra add-on therapies, rather than avoiding rejecting insulin therapy totally. But type 2 diabetes and post-transplant and other complications, during the complications also, SGLT2 inhibition we have very good, except those patients who are at risk of developing urinary tract infection, especially those with a neurogenic bladder, and diabetic cystopathies we don't use, and also the patients with a significant peripheral vascular disease and chronic smoker and having a known case of peripheral vascular disease, we don't use in these two people. Otherwise, SGLT2 inhibitions are good. The only thing is that you need to monitor initially for the first at least 2 to 3 months. We should be very, very careful, because they get into dehydration.
Other thing is probably we are not optimally using the ACE and ARB for prevention of DKD in type 1 diabetes or the type 2 diabetes.
Yes, sir. That is.
Yeah, actually, one of the work I attended, that Dr. Satish Garg's and group at in USA, they are giving good dose of what you call enalapril simply. That is the cheapest and the cost effective. And they are telling that they are giving up to 30 milligram of enalapril. Of course, our type 1 diabetes are very lean and thin as compared to their type 1 diabetes are indeed the robust. So we can use these drugs. Of course, SGLT2 inhibitor can be tried. There is no harm in that. But I think we are underutilizing the available molecules with us with this intention to prevent. And maybe in type 1 diabetes, especially, we are probably not very closely following their annual microalbumin screening is also not done appropriately. And most of the patient lending to us with the nephropathy before maybe the second or third stage of the CKD. So that is one of the things. So how much you are using in your practice? Anyway, I don't know, this being a nephrologist, not saying primarily type 1 diabetes. Those are referred to you after this certain stage only.
Yes,
So
yes,
I think
yes.
your role is limited, but the role of endocrinologist is main, and I'm sure in most of the place this is not the practice actually. We just look at the once the micronutrient sets in, then we'll start the
We in
something
the
else. So
nephrology
that is-
practice, we give ACE inhibitor or ARB to all diabetic patients.
Yeah.
And in fact, we have a literature in saying that even with a significant renal dysfunction, something previously people who are apprehensive about 2.5 to 3 milligram per creatinine. But now it is not the case. We are giving even 5, 6, 7 also. Only thing is we have to monitor the potassium very carefully. Literature also says that those patients who continue to take ACE inhibitor ARB beyond ESRD, so stage 5 CKD, they have there's not much of deterioration of the kidney function, but there's a cardioprotection was actually assured in them. So that's why we are continuing, even in ESRD, we are continuing that. Even on dialysis, we give ACE inhibitor ARB. So I think we are the abusers of ACE inhibitors ARB than anyone else. But as you are rightly stated, that Dr. Arundhati and other people should really highlight type 1 diabetic, because predominantly they stay with them. Yeah, as you
Yes,
said,
yes.
come to us only when there's at least our endocrinologist refers the case only when there's a microalbumin. Then only they will send, and we don't see them actually. We tell them that use this and you just go back to your endocrinologist. Don't come to us especially with microalbumin only. Don't worry, because that's a stigma that once they get into seek a kidney doctor, so there's a they are afraid to come to us.
Kidney
Tell
unit,
them
yeah.
that you continue with these drug therapies and you be with your endocrinologist only. Come to us once in a year. Something like that we tell them. I think hope for Dr. Arundhati also would accept that early institution of ACE inhibitor ARB in both type 1 and type 2 diabetic will be very good. So we can take her opinion also.
Are you recommending usage of ACE inhibitors even when there is no microalbuminuria? Because that is not something that we usually do. I mean, it's considered, whatever data we have says that BP control with ACE molecules, calcium channel blockers, RAS blockade or diuretics, still there is no microalbuminuria. Once you start getting microalbuminuria, of course, you'll have to shift to the RAS blockade. That is the, what we generally practice. Do you have any difference in your opinion out there?
Yes, actually, it is there that before the onset of proteinuria, there will be some significant histopathological changes that take place, especially the type 1. As I stated in one of my in my talk, that there is no correlation between histopathology and clinical course. And patient with a very worst histopathology can be normal proteinuria and normal renal function. Patient with a very significant renal failure clinically with a high creatinine proteinuria, there can be a simple histopathology inside. That's why before the onset of proteinuria itself, the changes are taking place very early. And if you start them early, ACE inhibitor ARB, they can be a reversal also. This also I stated in my talk, that the microalbumin level also can be reversed back. That's why it's important not to worry about the proteinuria and all, and thinking that ACE inhibitors and ARBs are very good drugs and they can change the intraglomerular hypertension and significantly postpone the onset of microalbumin only. Why do you have to wait till the microalbumin? That can be postponed in a significant duration if you institute the therapy very early.
I totally agree with you, Dr. Raju. Actually, there is some inertia on the endocrinologist part actually, and that is maybe very, very important. People, those are having a family history of CKD.
Yes.
In this type of group, already that is known that they are going to develop the CKD. In those type of patients, even without microalbuminuria, they may be given as a treatment. And rather than many people choosing the calcium channel blockers for the treatment of type 2 diabetes as an antihypertensive first line. I think first line, we should be very clear about that. May not be out of the speakers, but I like to, for the benefit of the audience, those are attending this session, that you start the AC or NS or the ARBs. Those are definitely preferred, and there are many other pleiotropic effect in addition to just controlling the blood pressure.
What generally happens is when we initiate an ACE inhibitor and ARBs, but sometimes the patients come to us who are already on calcium channel blockers and their BP is well maintained. They don't have any microalbumin.
I think, Dr. Arundhati, still I'll suggest we should change, because this is a very
please think of changing
simple practice. Just people in general, they just start calcium channel blocker just to worry they like cough or something like that. But if you go by the pathophysiology, then we are very clear that which drug is the best actually. So there is no harm in changing. And at least you can say, okay, you are taking 10 milligram of amlodipine. Let's make it 5 milligram and add another 40 milligram of telmisartan, or maybe ramipril 5 milligrams, something like that also can be done. That's this.
I have 2-3 interesting questions actually. A late flurry of questions that suddenly came in. So I would like to ask Dr. Arundhati that what is the difference between DPP-4 inhibitors and GLP-1 receptor agonists in terms of the cardiovascular benefits?
So we do not have data about cardiovascular benefits with DPP-4 inhibitor. All that we have data is about cardiovascular neutrality with DPP-4 inhibitors. But we have a lot of data with the different GLP-1 receptor agonists across the trials, the leader and others, wherein we have seen, and that was also shown by our speaker, our cardiologist here, the benefits that were seen in terms of the 3-point MACE, in terms of the cardiovascular mortality benefits and others. So if you're talking about benefits, GLP-1 receptor agonists definitely score over DPP-4 inhibitors, no doubt about that. What we have with DPP-4 inhibitors is that they do not cause any cardiovascular damage. They're neutral, but they have till now we do not have data telling us that they give us any added benefit in terms of cardiovascular, the 3-point, 4-point MACE or cardiovascular mortality.
One very quick question is about any red flag about SGLT2 use in patients with venous thromboembolism.
Venous thromboembolism, I do not, because we have some certain concerns with peripheral vascular disease. Venous thromboembolism per se, that would also depend on the patient in whom you're choosing. If it's a real sick patient who is, and the venous thromboembolism is in that context, that is not a patient where you would choose an SGLT2 inhibitor, at least in that point in time. But otherwise you would look at the context, the total, all the other comorbidities of the individual, and then decide on whether or not you're going to give an SGLT2 inhibitor to that patient with venous embolism.
Thank you. And I have 2 quick questions for Dr. Raju. One of them is, which type 2 diabetes patients should be selected for renal biopsy, and when should we start non-steroidal mineral corticoid drug finerenone, or maybe indications of finerenone?
This actually, we have been doing a small project study also with the Bayer now after the Fidelio and Figaro DKD trials. And I take up the second question first. The Figaro and the Fidelio trials also showed very clearly that the patients with the proteinuria and the patients with the GFR of more than 30 ml per minute, and they do very well. And those patients who are at risk of developing a progressive kidney disease are supposed to be given finerenone therapy. Finerenone is a very good molecule, but only thing is that potassium should be less than 4.8, and to start with, the GFR should be more than 30 ml per minute. And that can be given slightly low, even to 20 also sometimes. But only thing is the potassium should be monitored within 2 weeks after the initiation of therapy, then followed by once in 2 months for a few months, and then followed by once in 3 to 4 months. Potassium restricted diet is also should be advocated. But otherwise, finerenone is a very good molecule, and that can be instituted to all the patients with more than 30 ml GFR to start with. And coming to your first question of biopsy role in type 2 diabetic, and as I stated that we have a very big series of patients with the type 2 diabetic getting a biopsy done. And as I stated very clearly that these are the indications of severe nephrotic range of proteinuria and very short onset of nephrotic range of proteinuria, and also active urine sediment with the microscopic hematuria, proteinuria, and RBC CAS, and a rapid and recent deterioration in kidney function called rapidly progressive renal failure presentation, and presence of any systemic disorder, be it hepatitis B positivity, hepatitis C positivity, or a sarcoidosis, suspicious of amyloidosis, and any other vasculitis, especially in elderly population. And I told you that very interesting cases we found that more than 50% of the patients with the type 2 diabetes, when they undergo, will have a non-diabetic renal disease, like IgA nephropathies and membranous nephropathies, even minimal chain disease. And when we treat them with the steroid therapy, they wonderfully become good and the proteinuria disappears. So IgA nephropathies and untreatable conditions like fibrillary immunotactide and paraproteinemias with something like a myeloma nephropathies and monoclonal immunoglobulin deposit diseases. That's what I'm telling you. When you find an indication, better not to miss an opportunity to do a biopsy to see what's happening inside the kidney.
I think that was very crisp and to the point answers. I always feel that on a lighter note, it was really nice to pass your exams with 3 or 4 molecules to study, and within a decade of passing, having 8 to 10 molecules at your disposal to write. I extend gratitude to Corona Remedies for giving us this opportunity, and also to Dr. Bhadada sir for making this event happen. I thank all the speakers of the session, Dr. Arundhati, Dasgupta, Dr. Manoj, and Dr. Sree, Bhushan, Raju, and hand over the session to Dr. Bhadada sir. Thank you.
Thank you, Dr. Ameya. Very nicely conducted the session and made the discussion very vibrant and useful. And thank you and all the speakers. So with that, dot on time. Deciphering ADA 2023, an Indian perspective. The moderator for module 2 is none other than Dr. Vipin Talwar. Dr. Vipin Talwar is indeed in the field of endocrinology, my grandfather in that sense. When I joined PJ as a non-DM senior resident, he was my senior to senior. So I can say he's my grandfather in the field of endocrinology. And it's my privilege to introduce Dr. Talwar. Dr. Vipin Talwar is Director, Senior Consultant Endocrinology at Diabetes at Golden Hospital, Jalandhar. He is Chairman of RSCI Punjab Chapter, Joint Secretary of Punjab Endocrine Society, and is also President of Super Specialty Forum of Jalandhar. He has more than 56 publications as original articles, review article, and case report in index journals. He is actively involved in various activities, and for that, he received many awards and prizes. He is awarded Inspiring Endocrinologist and Diabetologist of India by Economic Times. He is also awarded Healthcare Pioneer of India by Government of Punjab. He is convener of Sathi, which is an NGO for the help of young diabetics. He is member of editorial board and article review committee for index journals, and is a speaker, moderator, and chairperson at various international national conferences. With this brief introduction, I hand over the mic to Module 2 moderator, Dr. Vipin Talwar. So, sir, all stage is yours. Please take care.
So, good morning, dear friends. At the outset, I thank Corona Remedies for having this wonderful discussing platform on this beautiful morning of Sunday, although it is raining in some places in North India, but my city is showing some sunshine today. And another sunshine in front of me is in form of Dr. Sanjay Bhadada, my dear friend. And it is always a wonderful experience to share DAS with him. May it be in person or may it be online. So thank you, Dr. Sanjay, for those sweet words of introduction.
Thank you, sir. Thank you, sir. And
with that wonderful first module, which has been discussing various aspects of some interesting topics which were discussed at ADA, we now move on to the second module. And for the second module, again, my dear friends, we have got very elegant topics which have been selected. And the speakers, again, they are again the Galaxio speakers with me. And I'm sure you're going to enjoy your Sunday morning. So the first presenter with me today is an endocrinologist, Dr. JayaPrakash P. So Dr. JayaPrakash is from a wonderful city of Cochin, also called as Kochi. So he's in the Medical Trust Hospital, and he has received many gold medals in his academic years. I don't know how many grams of gold is there in gold medals, but if it is there some gold, it must have multiplied in the money many a times, because today the gold price is 61,000 for 10 grams. And he's a trier of RSST Kerala branch. And also he has been the past trier of Endocrine Society of India Kerala chapter. So why I was discussing gold is because he has been the trier of almost all the societies. That's why he is more interested in economics part. That's why gold is also important. And he has got a professional association of the clinical endocrinology. And he will be presenting a very interesting topic. The topic is regarding the exercise and obesity. Dear friends, you will agree with me that obesity has come up with the epidemic in India. Few decades ago, India used to be at number 19 position all over the world as far as the obese population was concerned. But recent data, which has come a couple of years ago, shows that Indians, we have 5th largest population of obesity in the world. So we have this much of obesity, and we do talk about various molecules which take care of obesity, but we cannot afford all these molecules. Therefore, exercise and eating behaviors, that is lifestyle modification, will be very important in controlling obesity and its associated complications. And to just tell you one thing over here, recently a paper has been published which has shown that obesity is associated with 229 complications. It is not only diabetes, hypertension, other things. Total 229 complications they have been assigned to this single word of obesity. So what obesity is doing to us, we know very well. So what we can do to obesity, this is what Dr. JayaPrakash will tell us. So Dr. JayaPrakash, the stage is for you.
Thank you, sir. Thank you for the kind words of introduction, and I'm happy to share the dais with my super senior to you, and also Dr. Bhadada, who is my teacher in PGA. So I've seen much younger photos of you in our lecture hall, where we have seen the photos. So it's a proud privilege to share the dais with other my co-speakers also. And let me also thank Corona for setting the stage for this. As Dr. Talwar had told, it's improving the metabolic health, which is the topic which has been assigned to me. But unfortunately, it's rather I'm asked to discuss two preclinical or rather non-human studies which have looked at the time-restricted eating pattern and also the cardiometabolic health. So one is a study from Dr. Kylie Kavanagh. This was actually, the concept is to present those papers in ADA to discuss it in Indian context. So this paper was presented by Dr. Kylie with respect to the time-restricted feeding and how it improves the cardiometabolic profile. So this is actually a primate study, a non-human primate study. She had done it in monkeys, where there were two groups. One was given Western diet ad libitum. So they were allowed to feed whenever they were hungry. And the other group was given Western diet on a time-restricted pattern. So from 6 a.m. to 2 p.m., they were given access. So this intermittent fasting or time-restricted eating pattern, how it affects the primates also. This has been studied in this. And interestingly, they have taken two groups of non-human primates, the monkeys. One is the geriatric age and the non-geriatric adult age. So we know that it improves cardiometabolic health, but they've looked at how it is affecting the circadian gene expression and also the metabolic profiles. So the monkeys were studied after 2 months, after 8 months, and also after 12 months. So it was for a year that they were observed, and various parameters with respect to the adipogenicity or the biomarkers of adiposity, both adiponectin and the harmful biomarkers, every molecules were studied. The lipid profile was also studied. So what they found was that the lifespan actually didn't change. It is only for a year, so we cannot concur or give much importance to that. But the other parameters had significant difference. For example, in the ad libitum group, the serum triglycerides were higher. Whether it's geriatric or non-geriatric population, the triglycerides were higher. The HDL cholesterol was better in the time-restricted group. So both in geriatric and adult, the HDL cholesterol was better. There are also other complex parameters like the cholesterol efflux capacity. These parameters were measured, and it was found that the cholesterol efflux capacity was better in the monkeys who were exposed to time-restricted feeding. So this actually paves way for improving the cardiometabolic health. And what they concluded was that both the body weight and the adiposity was actually similar, and the lifespan also was similar in both the groups. But then the biomarkers of cardiometabolic health was better. So this probably gives insight into the human metabolic profile also, where we've seen the time-restricted eating pattern improves a certain metabolic profile, especially with respect to the cholesterol level, and how it translates into the mortality and morbidity, long-term mortality, for example, and the cardiovascular mortality and cardiovascular remand rate we are yet to see. So I think that was the first study. It was a pretty short paper. The second paper which I've been asked to discuss is with respect to circadian rhythm and metabolism. So this is from Dr. Aline Welge, who is a professor of pharmacology in Philadelphia. So as we know, with respect to circadian rhythm and endocrinology and also the cardiometabolic health, there are many aspects which have been already known. So the main clock or the regulator of the circadian rhythm is said to be the suprachiasmatic nucleus in the brain. And actually, it's a complex interplay, which is dependent on the photo entrainment of these neurocycles. So the solar cycle, as we know, the circadian clock with the light and the day and the light cycles, the suprachiasmatic nucleus senses this and sends signals to both the endocrine and the nervous system rhythms. So this is how the periodicity of the endocrine system, as we know, the hormones which increase as we rise up, and at the night time there is an nadir of most of these hormones. There is also a regulation of the nervous system, which the neural cycle also is entrained by the photosensitivity of the suprachiasmatic nucleus. So there is an interplay between this and the oxidative and metabolic cycles. Both the hormones and the neuronal cycles give signals to the metabolic cycles. And this is something which an individual is trained with as he evolves in his life. And also there are certain genetic factors which also predispose to this. So there are so many transcription factors, activators, which are being increasingly identified. So this study actually they have tried to throw more light into this mechanistic aspects. So the baseline is that metabolism studies, but this is actually a study which is being discussed, is a study which is done in the fruit fly, Drosophila. So there are studies which have been shown that the biological clock also determines the liver glycogen and the bile secretion. This, as we know, since many decades. So this factors, especially with respect to the human factors, there are so many other intervening or interfering things which has already happened, like the pollution level, the temperature control level, the food availability, the physical activity, then again time zone travel, shift work. All these factors are actually disruptors of the endocrine clock or the circadian clock. So all these activities, be it shift worker or the pollution level, where adequate sunlight exposure is not given to train this circadian rhythm clock. All these activities are, as we know, associated with obesity, associated with other metabolic conditions like fatty liver, then worsening of glycemic control, high blood pressure, high dyslipidemia, sleep disturbance, obstructive sleep apnea, insulin resistance, and even depression is also one of the comorbidities. So all these factors can drive the cardiometabolic complications and lead to poor cardiometabolic or metabolic and cardiac events. So in this study, they've tried to look at the glucose metabolism in the Drosophila, where they've actually given, it's a complicated topic, which I had to read through many things actually was beyond our knowledge as a clinician. But there are two types of Drosophila flies which they've studied. One is called as the fumin. Fumin is actually a mutant variety where it has decreased sleep-wake cycle. So Drosophila, as we have seen during our training days, Drosophila or fruit fly is a very good model to study, which even though it's an insect or a fly, there are many genes which are kind of similar to human genes. And surprisingly, this fly has also got a circadian rhythm, which is similar to the human circadian rhythm. And there is a sleep cycle also, which is similar to the human cycle. But this is happening at a much microscopic parameter level. So, but nevertheless, certain metabolic studies, which are impossible to be done in a living human or even primates, it's the fruit fly or Drosophila study which has given insight to this. So in this study, they've taken the wild type or the regular Drosophila, which is considered as a normal circadian rhythm, and a fumin mutant variant, which has got a disrupted circadian clock due to the disruption of the signaling in the suprachiasmatic nucleus. So what was done was that they used isotope tracer of carbon C13, which was given in both these types, and they were given, the 6 samples were analyzed during their day. There is a fixed sleep-wake cycle of this Drosophila, and the fumin has got a decreased sleep pattern. And they have plotted the metabolic parameters because it's a carbon skeleton which we can determine many of or most of these metabolic profiles, the Krebs cycle and glycogen cycle, gluconeogenesis cycle, 6 samples from each Drosophila. And they observed the diurnal rhythmicity, and the diurnal rhythmicity is, as expected, lesser in that fumin mutant. So those Drosophila which have not been able to maintain the circadian rhythm, the diurnal availability of molecules or the parameters are almost nil. So the major importance which they have given, the major insight that this study has given is that the insulin signaling, the insulin resistance and insulin sensitivity actually decreases in these fruit flies, which has got a mutant circadian rhythm or the fumin mutants. So both the cycles and the neuronal cycles are also, there is an aberration. The insulin signaling is decreased, especially this happens late in the evening and also early morning. So what they have seen is that the glucose values tend to rise early morning and also late in the evening. So the study concludes by telling that the metabolism which is observed in certain patients, which can be seen, which we have seen, which is associated with decreased sleep. For example, insomnia or shift workers who have sleep disorders or obstructive sleep apnea. The worsening of metabolic control, we have seen patients with high fasting blood glucose in that subset, and also more of cardiometabolic events. This is correlated with the decreased sleep cycle, and the metabolic fate of these molecules, which is determined by the suprachiasmatic nucleus, maybe some genetic changes are seen in these individuals. So there are certain epigenetic factors which are linked to the transcription factors also. So long-term disruption of the circadian rhythm, as we know, is associated with increased events and also poor metabolic health. So the mechanistic aspect, how this is happening, they have seen that it is probably a direct disruption of the signaling pathway of the suprachiasmatic nucleus, and which have led to this. So I think that's all. That those are the two studies which was given to me. One, as we have seen, is a non-human primate study where the metabolic health has been disrupted, where the time-restricted eating pattern has been shown to improve compared to ad libitum, round-the-clock intake of food. The second is Drosophila study, where they've seen that, yes, the mechanism of the disruption of the endocrine pathway and also the neural pathway is probably due to the genetic mediation of the suprachiasmatic signaling, which gets faulty in these individuals who are where there's a disruption of the circadian rhythm. I think that's it. Thank you.
So thank you, Dr. JayaPrakash, for that wonderful deliberation regarding the basic mechanisms and new studies which have come up at ADA regarding the pathogenesis of obesity. But as a clinicians, me and other guests who have logged in today will be more interested in learning something more about the clinical aspects also. So I will request all the guests who have logged in today to post their questions to Dr. JayaPrakash, which we can take at the panel discussion time, where we can discuss regarding the new molecules in the management of obesity and how the new approaches have come up to take care of this epidemic of obesity. So thank you, Dr. JayaPrakash, for the deliberation. I will come back to you in the question answer session. So from this concept of obesity pathophysiology, now we move on to the second part of the second module today, in which we are going to discuss something regarding the nephro component. And to discuss that nephro part, we have got Dr. Siddharth Lakhani. And this is the introductory slide for Dr. Lakhani. So Dr. Siddharth Lakhani is a consultant nephrologist, transplant physician at Jaslok Hospitals. And also he is director of his own center with the name of Lakhani Kidney Center at Prabhadevi, Mumbai. And he is member of many societies, and he has got many articles, research, and investigate trials. So Dr. Lakhani will be discussing with us very important aspect in the diabetic kidney disease management. Few years ago, till I can say a decade or so, once a patient has got the kidney disease in diabetes, the dictum was, yes, you control the blood pressure, take care of your glycemia, your progression of kidney disease will slow down. But last decade has seen emergence of new therapies and modalities, which even help in not only retarding the progression, but also it leads to regression or even reversal of some components of DKD, maybe at the early stage. So what is that mechanism? What is that molecule? What are those modalities beyond control of blood pressure and diabetes, which are going to help our patient with DKD, is what Dr. Lakhani is going to discuss with us. So Dr. Lakhani, I welcome you today morning, and the stage is for you to give your deliberation. You are mute, Dr. Lakhani. Please unmute yourself.
Thank you. Good morning, everyone. Thank you, Dr. Talwar, for the introduction. So as probably we are here to discuss probably the deciphering of ADA 2023. And my topic is much more exciting than probably what we are hearing routinely, is what do we have beyond this anti-hypoglycemic and anti-hypertensive agents for diabetic kidney disease. My talk will be divided into 3 parts. So are we following the guidelines for using the newer therapies to protect against DKD? What are the future therapeutic modalities? What we are going to see other than what we are already using for diabetes? And the newer molecules which are there, are they useful, or probably are they useful in children and adolescents with diabetes? So this is where I'm going to discuss. So now all of us know a lot of landmark trials regarding SGLT2 and GLP-RA1 has changed the outcomes and probably changed the working protocols in diabetes with time. As Dr. Talwar rightly said, the earlier protocol was to control sugars and good HbA1c levels, and that was probably enough for us to be happy that we are doing what we should do. Now the times have changed, where probably after studies, Credence, DAPA-CKD, EMPA-Kidney, trials have focused more on the cardiovascular and kidney outcomes. And further, all the guidelines which are there, the ADA and ACC 2020-2022 have focused more on complication-based therapy for diabetes. So earlier, what used to be like just control of HbA1c now focuses more on the atherosclerotic cardiovascular risk, diabetic kidney disease, CKD, and probably the heart failure related stuff. So if you see all the guidelines, though, the guidelines will focus on starting this. So if we read the ADA ACC 2020 guidelines have specified that SGLT2 are indicated probably in patients with diabetes, with CKD, heart failure, and an established atherosclerotic risk factor. The GFR which we are comfortable using these molecules is somewhere between 30 to 60, or probably a urine albumin creatinine ratio more than 30. So it focuses on diabetic kidney disease patients which will have more term risks of heart failure or an atherosclerotic risk factor, and also focuses on slowing down the disease where they are already focusing on urine albumin creatinine ratio, where they seeing early diabetic kidneys already set in for patients. So, and if we see even after probably last 2020 guidelines, still the use of these molecules, the GLP-1 RA and the SGLT2 is not yet frequent or rampant in all the patients probably who are into early diabetic kidney disease. Again, SGLT2 use in probably heart failure with reserved EF is recommended completely, and it is the guidelines have changed from the base 4 pillars. The SGLT2 becomes one of the 4 pillars of treatment of heart failure with reserved EF. So that is one more criteria. What are the barriers? So there are a lot of barriers even after having guidelines over last 2 to 3 years. There are multiple barriers of not using these molecules for the treatment of probably diabetic kidney disease or patients of diabetes with atherosclerotic risk factors. So what we see is, though the guideline recommends both the drugs, their use probably to reduce CKD and kidney risk in type 2 diabetes and CKD is much lesser. The SGLT2 and GLP-1 use in patients who will experience or have the most benefits, the use percentage is much lesser. So studies have shown that probably we'll need multidisciplinary collaborations across the care pathway, right from patient education to clinician education to probably more explanation of the drugs. And that is how we are going to probably take out the barrier and give maximum to the patient. Further going to what are the probably newer molecules which we are seeing? What we already know is right from your sulfonylureas to metformin to this SGLT2 and GLP-RA1, the ACE ARBs. And of course, for further molecules, we have ERNI or probably heart failure related kidney disease, we have this ERNI molecules. Now we are focusing on molecular levels. So if we see what drives the diabetic kidney disease forward, one is the hemodynamic alteration. So hemodynamic alteration is taken care by your RAS and the SGLT2. The most important factor which is found is the hyperglycemia, which leads to metabolic dysfunction, which leads to mitochondrial dysfunction. So we'll need something to focus on the mitochondrial dysfunction. At present, what we are using is the SGLT2 and GLP-RA1, which takes care of some part of mitochondrial dysfunction in the patients. The second most important factor which drives the diabetic kidney disease is the inflammation and fibrosis, which takes care with TGF beta 2. So whenever the disease sets in, slowly the inflammation and fibrosis will take care and will take the disease further. For taking care or mitigating the inflammation and fibrosis, we use the MRAs, the RAS, and the SGLT2. Now coming towards the mitochondrial probably dysfunction. So if we see in any case of diabetic kidney disease, there will be probably at the level of cells, there will be hypoxia, there will be a protein modification or a glycation asphylated glycated products, which will start affecting the mitochondria. And there will be an increase in reactive oxygen species. This all will lead to mitochondrial dysfunction, and mitochondrial dysfunction will further lead to progression of diabetic kidney disease. So this is how we probably, the target is now mitochondrial dysfunction. Second, we have the oxidative stress and the inflammation. So if we agree, hypoglycemia leads to a constant state of oxidative stress, and that leads to a constant state of meta-inflammation and metabolic dysfunction. So multiple molecules have been worked on for meta-inflammation. That is baricitinib, pentoxifylline, the non-steroidal MR antagonist, the endothelial A antagonist, the mineralocorticoid receptor antagonist, the TGF-beta, the perfenidone. So these are all multiple molecules which are into the trials for probably reducing the oxidative stress and inflammation and trying to slow down the diabetic kidney disease, rather than what we're using already for diabetic kidney disease. We have targeted therapies towards the NAD plus augmentation. So the nicotinamide augmentation, which again is a major role, which causes glomerular dysfunction and albuminuria. So whenever there is a decrease in conversion of nicotinamide to NAD+, there will be a significant glomerular dysfunction, and that will lead to albuminuria. So multiple studies have been done to probably take care of this NAD+, and NA+ augmentation clinical trials have been studied. Multiple studies have been done, which are probably into the pipeline. The next in the row is the JAK-STAT pathway, the Janus kinase signaling transducer and activator transcription pathway, which again probably slows down the fibrosis. JAK2, we, as all of us know, JAK is probably in multiple diseases. So that is where studies have been done. The baricitinib is a molecule which is probably used, and in one of the studies they have probably studied 129 patients with a GFR of 45 and a urine albumin creatinine ratio of somewhere between 400 to 1600. And baricitinib was shown, a 4 milligram use of baricitinib had significant reduction of urine albumin creatinine ratio by around 41% use at the end of 24 weeks. So that is significant reduction of albuminuria, which we are seeing from the probably JAK-STAT inhibition pathway. It also reduced significant inflammatory markers in the study. So this is how, again, one more study which takes care of things. As I already discussed, the kidney fibrosis, which remains as an important part of the diabetic kidney disease progression. And TGF-beta, as all of us know, is the major molecule which takes care of this probably kidney fibrosis, which is taken care of. So multiple studies have been done to have the inhibiting signaling pathway of TGF-beta. And as all of us know, perfenadine is been the molecule which takes care of this. So it has been tried in both diabetic kidney disease type 1 and type 2. And perfenadine probably has been shown to reduce the inflammatory markers and reduce the fibrosis in these patients, which were studied. Multiple ongoing trials are going on. We have the pentoxifylline in diabetic kidney disease trial, the PTX-RX trial, a phase 3 trial of bardoxolone methyl in patients with diabetic kidney disease, the AYAME study, which is going on. We have the finerenone already in the market, which is there, finerenone in type 1 diabetes, the FINE-1 trial, which is still going on. And we have the Mosaic trial, which is use of celocernib in the patient with diabetes. That is again study which is going on. So multiple biological mechanisms behind the mitochondrial dysfunction and oxidative stress are the attracted targeted molecules, which we are going to see in future use. Most important parameter for reducing or slowing down diabetic kidney disease is timely intervention. And combination of multiple therapies targeting different biochemical mechanisms to mitigate or slow down the diabetic kidney disease will be the key in future. And we still need multiple clinical and randomized trial to focus mitochondrial dysfunction and oxidative stress in type 1 diabetes, which is still lesser. Most of studies which are done are in type 2 diabetes. Coming to probably the last discussion point is, where are we on these molecules in use of probably children and adolescents? So as all of us believe, obesity, dyslipidemia, hypertension, the scene of type 1 diabetes, and a part of vitamin D deficiency and the early fatty liver, which we see in a lot of adolescents these days. So this is probably been to be taken care of, as we don't in longer term, this is going to progress much faster. So if we see, FDA has approved multiple molecules to treat pediatric type 2 diabetes, and which includes metformin, the liraglutide, the exenatide, the empagliflozin, metformin combination, and the semaglutide. So multiple molecules, right from SGLT2 to the newer generation molecules which we are seeing, has been tried. SONAR trial was one which studied probably adults between 18 to 85, though the age group was wider, but it studied probably use of multiple molecules in pediatric patients as well. So to conclude, probably further studies to see for youth and diabetes will be needed, and on front of kidney specific endpoints will be needed to probably use. There will be a therapy probably in youth to see care of SGLT2 use wherever possible. SGLT2 along with MRA to reduce the risk of hyperkalemia, SGLT2 with endothelial reception antibody to see for fluid retention, and multiple combination drugs in future, as we discussed, to slow down the diabetic kidney disease progression, which we are seeing, rather than focusing only on HbA1c and sugar levels, which will not help us. So this is where I probably conclude. Any questions, we'll take it at the end. Over to you, Dr. Talwar.
Thank you, Dr. Lakhani, for that wonderful and crisp presentation regarding the aspects of treatment beyond diabetes and hypertension control in patients with diabetic kidney disease. Definitely, I'm hopeful that many questions will pop up in the chat box, which we will discuss in the panel discussion time. So once again, I thank you, Dr. Lakhani. Stay tuned. Now we move on to the third part of the second module, my dear friends, which is to be discussed by a very eminent cardiologist, Dr. Soumitra Kumar. So Dr. Soumitra Kumar, he's a consultant and cardiologist at Fortis Hospital in Kolkata. He has been a past honorary secretary of CSI. He has been a national and West Bengal branch past president, and also has been a past president of West Bengal Academy of Echocardiography. He has got 150 publications in national and international journals, and he has been an editor of a text in cardiology, which is the current trends in cardiology, and it has gone through 2 editions. And also he has authored an evidence-based guideline book on the management of cardiovascular and related emergencies, 5 editions of protocol book for intensive care, and he has been a joint editor of another book, Echocardiography in Clinical Practice, and another book on acute coronary syndrome, along with Dr. Cannon. And also he has got a published treatise which has been titled Clinico Echo Ensemble. He has been associate editor of Non-Specific Aortoarteritis, a monogram, then CSA textbook cardiology. So my dear friends, we see that we have got a highly literate person who has contributed not only the clinic, but also to the academics. And the topic which is assigned to him is again very interesting. It is regarding the diabetes cardiomyopathy. And once a patient has got diabetic cardiomyopathy, it is okay. What we can do at earlier stage, how we can diagnose this entity of cardiomyopathy, that is diabetic cardiomyopathy at early stage. So what we can do for this diagnosis so that we can have the better management of the disease is what Dr. Soumitra Kumar is going to discuss with us. So Dr. Soumitra Kumar, please step in.
Yeah, thank you, Dr. Talwar, for the kind words of introduction. Good morning, everybody. So the topic has already been spelled out by Dr. Talwar. It's diabetic cardiomyopathy. So whenever a patient of suffering from diabetes, be it type 1 or type 2, presents to us, the big question is that, is it diabetes per se which is causing the problem, or is it some underlying other pathology? Maybe in adult patients, is it most commonly coronary artery disease, or maybe at the macrovascular level and even at the microvascular level. So that brings us to our topic, whether diabetes per se can cause cardiomyopathy, which we refer to as diabetic cardiomyopathy. Now, there have been 3 papers related to this, which have been presented in ADA this time. One was on the cross-sectional analysis of a large cohort of patients with diabetic cardiomyopathy enrolled in a longitudinal study. It's called the ARISE HF trial. Then we had another trial showing how to diagnose diabetic cardiomyopathy at the early stages based on the circulatory biomarkers. And then we had also some presentation on molecular mechanisms of diabetic cardiomyopathy. So starting from the clinical aspect to the molecular level, we had a lot of presentations in ADA this time on diabetic cardiomyopathy. So before I talk about the trials which are presented, so what is the entity of diabetic cardiomyopathy? As I said, whether diabetes itself can cause damage to the cardiac musculature, its structure, and its function. Yes, it can, as the presentations show and as we have known. So diabetic cardiomyopathy basically presents to us in the stage B of heart failure. The stage B that has been, we have been reading about it from 2013, when 4 stages of heart failure, as you know, stage A, stage B, stage C, and stage D were enumerated. So Stage A is largely the presence of risk factors which we have known to be precursors of heart failure. Stage B, actual structural and functional alterations take place. Stage C is, of course, overt heart failure, and stage D is refractory heart failure. Now, diabetic cardiomyopathy, where basically it is diabetes only presenting with a cardiac muscle structure and functional abnormality, can affect both type 1 and type 2 diabetes. So that is the first point that should be highlighted. Now, as I said, it is a stage B heart failure, which we refer to as diabetic cardiomyopathy, because when patients present to us later on, it may be a conglomeration of other other conditions also. It can be coronary artery disease, it can be CKD. But basically, our main focus of today's discussion is how to identify diabetic cardiomyopathy at this earlier stage, that is stage B. Now, mind you, as I said, already while in stage A, the metabolic derangements already start in the cardiac musculature, but it is basically in stage B that we come to diagnose this with the various tools that we have, either in the form of cardiac biomarkers or specifically with cardiac echocardiography in its very advanced form, including tissue Doppler imaging, strain imaging, etc. Now, one common thing which patients often come and tell us, doctor, I'm not feeling as strong as I used to be. My functional capacity has been reducing over time. Now, this is often we tend to ignore, and we take it as either some psychogenic abnormality or we ascribe it to some other factors. But this is something we have to take with all seriousness, and because that is the starting point of diabetic cardiomyopathy. And as we progress from stage A to stage D of heart failure in patients suffering from diabetic cardiomyopathy, there is a progressive decline in the functional capacity. So if we say the functional capacity is X in stage A, there is a 25% decline from stage A to stage B, and there is approximately another 25 to 30% decline as we progress from stage B to stage C. So this is something, one of the points to be highlighted. Now, how to diagnose diabetic cardiomyopathy at the earliest stages? So basically, echocardiography is a tool which is readily available to most of us cardiologists and even to other specialists as well. So basically, we look at the total LV mass, that is one of the first abnormalities, then the left atrial volume index. We look at the E by E prime ratio, that is at the diastolic filling abnormalities, and a very important tool which has been available to us in last 7-8 years like that is strain imaging. Now, strain imaging, we have found out it begins to decline right from stage A, and the decline is all the more evident in stage B. So whenever you are advising for assessment of a suspected case of diabetic cardiomyopathy, you always insist that the patient undergoes strain imaging, not only of the left ventricle, but I would recommend also of the left atrium. So this strain imaging is very important entity which should be highlighted. And we can add to this assessment of the RV systolic pressure or pulmonary artery systolic pressure. Apart from that, I mentioned about the biomarkers. The main biomarkers are NT-proBNP and high sensitive troponin. And as I'm going to tell you later, that there is a prediction which can be based on NT-proBNP measurement. And of course, whenever we are diagnosing diabetic cardiomyopathy, we have to exclude concomitant significant valvular heart disease, coronary artery disease, any congenital heart disease in the patient, and whether the patient has uncontrolled hypertension. So just to recapitulate quickly whatever I've said, don't ignore the complaint of physical poor exercise tolerance from the part of the patient. Take it seriously, assess it with biomarkers, and do a full-fledged echocardiographic study. Now, another very important tool in our hand to assess the patient's functional capacity is, of course, cardiopulmonary exercise testing, which measures the VO2 max. And if that is a tool available to us, that is also very sensitive. As I'm going to tell you in one of the trials measured, that is one of the primary endpoints in terms of VO2 max assessed. So that is also a very important tool to assess patient's functional capacity. Now, coming to the trial that was presented by one gentleman from Massachusetts, New England, Dr. Eskowitz. It is a trial called ARISE Heart Failure. It is an efficacy study to evaluate the ability of a novel and highly selective aldose reductase inhibitor, AT001, to prevent the worsening of diabetic cardiomyopathy. So aldose reductase, as you know, converts glucose to sorbitol, and this sorbitol and its other products in turn causes a lot of damage to cardiomyocytes. So this is one of the endpoints. As you know, glucose is a very energy efficient molecule. So on one hand, there is energy depletion of the cardiomyocytes. On the other hand, because of increased aldose reductase activity in the cardiomyocytes in diabetes, there is production of sorbitol, which can cause further damage by increasing the osmotic stress, by causing oxidative damage, and by promoting cell death or apoptosis. So this is the trial is looking at. About 675 patients have been enrolled, and they have been divided into 3 groups. One is the placebo group, and the other 2 groups have been given 2 dosages of this new molecule AT001 in 2 dosages, 1000 milligram BID and 15 milligram BID. And the primary endpoint, as I said, is the functional capacity measured by VO2 max by CPET, cardiopulmonary exercise test. There are a number of exploratory secondary endpoints also. So they being the progression to overt heart failure, then a measurement of serial NT-proBNP, and the quality of life score in the form of KCCQ score. So this is in nutshell about the study. The study is ongoing, but some facts have emerged already, which has been presented in the ADA this time. So these patients were already on the state-of-the-art medical therapy. They have been receiving statins, they have been receiving RAS blockers, and they have been receiving the various oral hypoglycemic agents that are available, and also insulin. In fact, almost 20 to 25% people who are receiving SGLT2 inhibitors and GLP-1 receptor agonists in this trial. So patients were already on the state-of-the-art medical therapy, and on top of that, this new agent AT001 was being tried. And in fact, 8% of people were receiving both SGLT2 and GLP-1 receptor agonists. So if this new agent AT001 produces some productive results outcomes, then definitely it is a molecule for the future. Now, what about this new molecule? We have had aldose reductase inhibitors in the past, mainly used for coronary, diabetic microvascular complications. Yes, they were successful to some extent, but they produced not very potent in the first place, but they had also some side effects because of aldehyde reductase inhibition also. So this time we have a more safe and more potent and more selective aldose reductase inhibitor that is being tried, which is called AT001. Now, serial NT-proBNP screening, as I said, is going to be done in the trial. Now, whatever results are available, now the VO2 max, the primary endpoint, has been divided into 4 quartiles. The lowest, the quartile 1 has a very low VO2 max of 10 point something, and the best one, the quartile 4, has more than 20. What has been found out that people who have who are on SGLT2 inhibitors and GLP-1 receptor agonists tend to fare better as expected. And another thing which has been found out that those who have very high NT-proBNP at the baseline, they tend to fare worse. So, as I just to highlight the points again, NT-proBNP is a very useful marker. The next study that I'm going to present is one from Professor Januji, who presented the diagnosis of diabetic cardiomyopathy based on the circulatory biomarkers, and he came to a very strong conclusion that anyone with an NT-proBNP level more than 125 picogram per ml are at a very high risk of further cardiovascular events, the most common being heart failure hospitalization. So if you, it is likely that the ADA will come up with a guideline to assess NT-proBNP and also HS troponin I or troponin T, whatever is available, at least once annually in all patients of stage A and stage B heart failure. And those who have NT-proBNP less than 25 picogram per ml are better off in that they have a very low risk of cardiovascular events and heart failure hospitalization. So this is one of the very strong comments that this trial, the second trial on circulatory biomarkers, have come up with. And coming to the last part of my presentation about the mechanisms at the molecular level, what is diabetic cardiomyopathy? Why is it happening? Now, as I've already said, so if aldose reductase activity is increased in the cardiomyocytes, what happens? We have less of glucose and more of free fatty acid oxidation. So that is not energy efficient for the cardiomyocytes. So there is energy depletion on the one hand. On the other hand, there is more of osmotic stress, there is more of oxidative damage, and there is more of apoptosis. So this is something which is this new agent, if it is successful, as is being studied in the ARISE heart failure trial with 80001, is going to show us whether aldose reductase inhibitions selectively can prevent the progression of diabetic cardiomyopathy from stage A to stage B or even to stage C. So this is something we are going to find out from this trial of ARISE heart failure. So to conclude, I'll highlight the major findings on diabetic cardiomyopathy and what is the take-home message. So the major message is that cardiac mitochondrial insulin resistance occurs in diabetic cardiomyopathy. So that is all what we know. And myocardial glucose oxidation is markedly decreased in diabetic cardiomyopathy. Myocardial fatty acid oxidation increases in diabetic cardiomyopathy. Myocardial ketone oxidation is also decreased in diabetic cardiomyopathy. So stimulating glucose oxidation by inhibiting pyruvate dehydrogenase kinase can lessen the severity of heart failure, and increasing ketone supply, in fact SGLT2 inhibitors does that, to the heart can increase cardiac energy production in diabetic cardiomyopathy. So with that, I'll end my presentation. Thank you very much.
So thank you, Dr. Soumitra, for very nicely presenting the data from the ADA regarding the early diagnosis of diabetic cardiomyopathy. And now I think we have got some time left with us for some discussion. And I think that discussion may be beyond what we all have discussed and listened from the three eminent speakers, because I've got a couple of questions which will be of interest for the clinicians who have logged in today. So the first part of the question will be for Dr. Soumitra Kumar. Dr. Bhadada, are you there?
Yes, I am there. Yeah.
So, Dr. Bhadada, I'm going to pose some questions to the speakers, which will be of help to the practicing physicians who have logged in today. So first question is to Dr. Soumitra Kumar. Dr. Kumar, as a diabetologist or as a physician or endocrinologist, we do come across diabetic patients a lot, and many of them, they're asymptomatic for their coronary artery disease. So we got recommendations regarding doing HbA1c every 3 months, the microbinuria every 1 year or so. So what is your suggestion regarding the screening for any cardiac abnormality, that is coronary artery disease, in an asymptomatic patient with type 2 diabetes? At what modality you suggest? Is it ECG or is it echocardiography for every patient?
Yes, ECG is the first line test. I mean, it's still standard, but you can't make a diagnosis of any evolving cardiomyopathy based on ECG. I mean, unless there are very overt features of left ventricular hypertrophy or left atrial enlargement, which is evident in the ECG, but many times it is not. So my advice would be to go for resting echocardiogram, as I said, and you have as practicing endocrinologist, nephrologist, or whatever specialist you are, you have to ask for a state-of-the-art echocardiography. That should include estimation of the left ventricular mass, left atrial volume index, a foolproof strain imaging study of not only the left ventricle but also of the left atrium, because much of the diastolic dysfunction starts at the atrial level. So along with left atrial volume index, left atrial strain study should also be done for the reservoir strain. And finally, the E by E prime and the diastolic filling pattern. In fact, you'll be surprised to find that many people have, one or more abnormalities amongst these four entities, even in the resting phase. And if you are suspect, if your patient complains to you that, doctor, I am not feeling as energetic as I used to be 6 months back, then you should not take it very lightly. You can subject the patient. If CPET is not available, I know it is not very easily available, it is expensive, but at least it can be done. You can ask your fellow cardiologist to do straight cardiography. And in fact, can be subtle or covert at that stage, underlying cardiomyopathy or changes happening in the cardiac musculature in the very early stages. So whatever is normal at rest can be unmasked by a stress echocardiographic study. So this is my advice, and if the patient can afford, you should also go for at least one biomarker assessment, namely the NT-proBNP. And as I said, any value above 125 picogram per ml should caution you that probably my patient is going to develop heart failure in coming months or maybe years. So this is my primary advice.
Yeah. Dr. Bhadada, as I mentioned this question, what is your recommendation regarding the echocardiography in asymptomatic cardiac patients? Because in practice, every patient has to pay for the echocardiography, say about 1.5 thousand rupees. So do you suggest that we should go with the echo yearly or 2-year interval?
Yeah, I think you may not be exactly, because we cannot use a blanket statement each and every type 2 diabetes patient, because probably, like interestingly and unfortunately, we don't have any clear-cut guidelines today. Like for nephropathy, we know that at onset you screen the patient. For type 1 diabetes, after 5 years you screen the patient. From the coronary artery disease perspective, the cardiac perspective, these things are not there. But if patient can afford, I say we have to do that also, because we know that more and more younger patients are developing coronary artery as well as the heart failure, which is almost, I think, there is sharing CAD and heart failure, both are sharing. The heart failure is 50% because of cardiomyopathy and 50% because of the CAD, I think. So recommendation is not there, but I think if we are proactive, I say yes.
Fine. And what do you think about this BNP or pro-BNP? Because again, this is an expensive test, and heart failure is many a time occult. You do not manifest heart failure in many of patients till it is in the stage 2 or something. So do you suggest BNP in the patient, at least who can afford it?
Yes, yes. And in fact, it is already in guidelines.
So, and how frequently?
They say that once in a year or as and when symptoms are there.
Okay.
Yeah, it is some guideline, it is there.
Thank you for that input. So second part of the question, or the second part of the story, is with Dr. JayaPrakash. Dr. JayaPrakash, you have given us a very nice overview of the basics regarding the obesity pathophysiology. So in clinical practice, we do have some molecules which take care of the obesity. So what is your experience regarding the time test orlistat? Do you use it in your practice, and how effective it is?
No, sir, I don't use it. I don't think it is suitable for our type of diet. We are mainly carbohydrate-rich diet. And in those select patients in whom probably orlistat, as we know, works by inhibiting the fat absorption. So in those select patients in whom it can be used, even they are not happy because of the side effects, because of the frequent loose stools that they have to encounter. Even sometimes involuntary soiling can occur. So orlistat is as good as not to be used in the kind of, at least in Indian setting.
Yeah, but I think nowadays we have better drugs like oral semaglutide. I know it is very costly, but in our experience, sir, it is really working very well. Some of the patients may wonder. And need not to go to 14 milligram, even 7 milligram is good enough, or 3 milligram is also doing good. So if you really were thinking about the weight reduction in type 2 diabetes, I think cost is issue, definitely. And many patients cannot afford that, is
Perfectly
for
fine,
sure.
Dr. Bhadada, because semaglutide, now the new trial which has used 50 milligrams of semaglutide.
Yeah,
The
Oasis trial, they have
has
used
led on
50
to
milligram and 25 milligram for the weight reduction. So, but
it
sir,
has shown
in our
weight reduction of
experience,
almost 25%. Yeah. And
that's
what is your insight regarding the newer molecules which are upcoming? The GLP-1 and the GIP combination agonist like tirzepatide. So that is again another molecule which is there in the pipeline, recommended by ADA for obesity management, reduces weight by almost 25%. And then again, now we got a triple molecule, that is GIP, GLP, and glucagon. That is a retatrutide. Again, it shows a promising result. Maybe in the next ADA
I
update,
think, sir,
we'll have
that is
some more talks about that.
New era is coming for these drugs actually now.
But
New
only
era
thing is the
coming.
cost, again, as we
How
say.
our patients, cost
Yes.
and tolerance, as Bhadada was telling, even 7 milligram, they always tell to uptitrate to 14, but 7 milligram itself, most patients don't tolerate. 14, I've seen very few patients tolerating that. But yes, Sarah told, we see weight reduction, very good weight reduction with even 3 and 7.
Patient may tolerate, but his pocket may not tolerate. That's another aspect. Because it has
Either way,
proven for
some
months
patients
together.
pocket tolerate, some patients.
But the cost between 3 and...
Yeah. So, Dr. Lakhani, are you there? So I had a question for Dr. Lakhani. If he is not there, then I will think Dr. Bhadada is going to answer this question. Dr. Bhadada, for this renal protection, Lakhani has come. Yeah. Dr. Lakhani, I was just going through one question for you, that we have got now the almost 3 molecules for the kidney protection. That is the SGLT2 inhibitors, the ARB ACE inhibitors, and now this finerenone, which is MRA antagonist. So do you start these molecules sequentially, and in what sequence, and can you use them together?
Yeah, so as rightly said, we are using probably molecules in a sequential way for all patients probably. So to start with, of course, as all of us believe that probably ACE-ARB has the maximum benefits, whether it is cardiovascular mortality, slowing down of diabetic kidney disease, or probably control of blood pressure, which is an important part for all diabetic kidney disease, or probably atherosclerotic cardiovascular disease patients. So start is with ACE-ARBs. If they tolerate that well, of course, once their proteinuria is there, there is no probably a risk of previous UTI, because we see a lot of diabetic patients with UTI. If there's no UTI sort of thing, then we add probably an SGLT2 also. If the sugars are not well controlled, definitely 10 milligram of DAPA or a 25 milligram of EMPA. And finerenone is added, though the cost of molecule is higher. So once where they can afford, that is added probably as a third molecule. So this is free, and then routine proteinuria checkups probably at 3 monthly or 6 monthly period to see for the reduction of albuminuria, which we usually advise patients. That is how probably the use of these 3 molecules have been there on a routine day-to-day basis. The role of MRA is probably very important. So we've seen a lot of MRAs helping patients in edema as well as slowing down of fibrosis, as I discussed during my talk, because it inhibits significantly the TGF-beta. So though when ACE and MRA both are added, sometimes they develop hyperkalemia and jump of creatinine. But if it is with cardiac, if it is with low ejection fraction, if it is with a cardiomyopathy, then probably we add on to MRAs also. This is how the treatment for a diabetic kidney disease will look like.
Thank you very much, Dr. Lakhani. And Dr. Bhadada, there is a very interesting question which has popped up in the chat box, not related to any of these 3 talks. That is that once a patient is on intermittent fasting and he develops gastritis, what you will do?
Intermittent fasting and gastritis. gastritis. So I think only issues maybe patient might be having some already gastric ulcer or something like that. We have to rule out that, not on the intermittent fasting, but might be having earlier, and which is precipitated by not eating for a long time. And I think that is one of the maybe a side effect of intermittent fasting kind gallstone disease formation that can present is a dyspepsia. That may be one of them. We know that this is one of the cause for the gallstone formation.
So perfectly fine. So the question has been well answered, that once a patient gets gastritis while being on intermittent fasting, investigate and see if there is any anxiety in the patient also for not eating for a long time. So the anxiety may also be because of gastritis. So with this, I close the session and I thank all the speakers for their beautiful presentation, Dr. Soumitra, Dr. JayaPrakash, and Dr. Siddharth Lakhani. And I hand over the mic back to Dr. Sanjay Bhadada.
Thank you, Vipin sir, for nicely taking care of this module 2. And we have wonderful discussion and the wonderful question answer session, as well as very 3 interesting, nice talks. So thank you, sir, once again. And now we will move on to the module 3. And the moderator for module 3 is Dr. K. Kunhali. Sir is MBBS, MD Medicine, DM Cardiology, FISC, FCCP, FIAE, FICA, IFESC. Is Chief Cardiologist at Malabar Hospital, Kozhikode. Senior Consultant Program Director of Heart Care Center at Calicut. He was also Chairman of KSDP Allapuzha. He is a member and patron of many social and professional association and organizations. He is honored more than 24 international and national awards. He is founder, president of Kerala Heart Care Society, the first registered organization in Kerala of heart disease awareness. He is author of the book Satskriya Kodate Hridayaghat Chikitsa. I'm sure not spelled wrongly. And he and his family are funded the Heart to Heart project of Kerala Heart Care Society, treated more than 300 patients with multivessel disease. With such illustrious CV, I hand over the mic to Dr. Kunhali to take the proceedings further and have a nice discussion. Good luck, sir, and all this mic is yours.
Thank you, Dr. Sanjay Bhadada, for the excellent introduction. I'm indeed very happy to be part of this Corona Remedies program. And I must congratulate them for picking up such good speakers. Now we have reached the 3rd module. And in the 3rd module, we have 3 very eminent speakers. And the first speaker is Dr. P.P. Mohanan, and he is going to tell us about new treatment possibilities for cardiovascular residual risk in diabetes. Mohanan is a well-known speaker, not only in Kerala, but all over India. He is a good friend of mine, and he is director and editor of the Department of Cardiology at the Westford High-Tech Hospital, and he is the Chief Interventional Cardiologist. He is the past president of the Cardiological Society of India. He has published a large number of papers, and he has published the largest acute coronary syndrome registry from India. And he did the largest randomized study in cardiovascular science from India. He did the first quality improvement study in chronic heart failure. You know, the first topic is new treatment possibilities for cardiovascular residual risk in diabetes. Until very recently, many of us thought that if you treat a patient with diabetes and heart disease with the standard care, everything is done well. But recently we know, and there are a lot of studies which show that there is significant residual risk even if you treat the patients with the standard care. So to tell us more about this, we have Dr. P.P. Mohanan from Tricur, and I have immense pleasure to invite him to present the paper. Dr. Mohanan, the floor is yours. Thank you.
Thank you, sir. Friends, we are all aware that despite the unprecedented advances in the treatment of atherosclerotic cardiovascular disease, it remains the leading cause of death and disability. Even in year 2020, approximately 19 million people died of cardiovascular disease. Treatment of major traditional risk factors, including the LDL, and we have been working more on we have been more LDL centric all these years. But as Professor Kunhali was earlier mentioned, a significant residual risk remains despite the optimal risk factor management. And that is possibly more relevant in diabetics. Now we have very potent LDL lowering agent. I am sure you are aware of the PCSK9 inhibitors in the Fourier trial using avlokumab. The LDL level was brought down even to 30 milligrams. But even then, there was a recurrent cardiovascular event rate 3 years ago, around 10%. So we have a problem of residual risk, and there could be very many reasons for that. There are residual inflammatory risk, and we have more and more data from various trials and involvement of anti-inflammatory drugs. I'm sure some of you would have heard about the CANTOS trial using Kanama. Now we have recently the cold clot trial using a cheaper drug like colchicine. So one area is the inflammatory area. We are not touching that. And the second area is the residual thrombotic risk. And here again, we have newer data coming up with using smaller dose of NOACs. So that will take care of the thrombotic rates. What we are concentrating today is the residual metabolic risk. And one amongst them will be the importance of triglyceride and the remnant cholesterol. Triglyceride, if you remember, we used to call it the ugly cholesterol earlier, but then it is no more ugly. The triglycerides and the triglyceride-rich lipoprotein has been identified as an important contributors of residual risk. Basically, they are derived from the diet, chylomicron and the remnants, and of course, the liver also manufactures substantially VLDL and that's circulated. There are several studies which have shown, both epidemiological, genetic, has shown there is a close association between TG and the residual moiety. But then, and possibly the Mendelian data also supported a causal role. But here again, I should admit that even today, we have been mostly centric on LDL. Basically, maybe because the agents which tackle the remnants and the triglycerides were not very popular. Now we have the report from the REDUCE trial using basically the EPA was used, eicosapentaenoic acid. When you give 4 grams of eicosapentaenoic acid, REDUCE showed a 25% relative risk reduction in the primary endpoint of cardiovascular death and MI. But then that is one aspect of it. Here again, we are not very sure, especially if the LD is on the lower level, what is the advantages of aggressively pursuing a triglyceride reduction policy is not yet well elucidated even now. One of the agents which we thought it was promising was the permafibrate. But then the prominent trial showed that the CVD risk reduction was not to the way that we liked. We know the patient with diabetes have a very mixed atherogenic lipid profile, and triglyceride is one of the important culprit. Currently, now we have 2 agents two RNA interfering agents targeting the genes for apolipoprotein C3, and also, these are all tongue-twisting names, angiopoietin-like protein 3, ANGPTL3. So these are the two important development that is happening in the last few years. So two types of agent, one concentrating on ApoC3 and one targeting the ANGPTL3. So there are again the agents like vupanosan, which tackles the ANGPTL3. This is a second generation agent, and we have some data that translate MI data. But then even despite these data, how much they're going to be of use for us is something that we have to see when we have a larger trial data. So olezarsen, again, one of the antisense RNA oligonucleotide, and volanesorsen, I admitted that I don't know whether I am correctly pronouncing it, but then these are volanesorsen is an ApoC3 inhibitor. So which will you choose? Will you choose a ApoC3 inhibitor, or will you choose a ANGPTL3 inhibitor? Well, it seems that whatever data we have, the ANGPTL3 lowers the LDL better than, apart from the TG reduction. Apart from the TG reduction, which is substantial, they also lower the LDL better than the ApoC3. So possibly, if you want to pick and choose, maybe we can possibly pick and choose the ANGPTL3 inhibitors, which I'm sure is on the anvil, and we will have a taste of it soon to come. That's what I presume. The next area which I just wanted to touch upon, Professor Kunhali, is the importance of LPA. I mean, LPA, we have been, I'm sure, even from 60s, we have been reading about LPA. We always thought that it will have, especially in Asian, if you remember, we have a gentleman cardiologist from Kerala who did a lot of data on LPA based in USA, and he popularized the concept of LPA, but then it was forgotten. It was forgotten not because of its importance. It was forgotten because we never had an agent which substantially reduces LPA. Whether you should routinely check LPA in every person, we don't have any strict recommendation. The European Society of Cardiology and the European Atherosclerotic Society recommend a universal screening for LPA in all adults at least once during their lifetime. That's all. Okay, so, but then there is an increasing interest now, because we have the PCSK9 inhibitors. Both the evolocumab and alirocumab trial showed that they could reduce LPA better than any of the drugs. Now, our conventional drug like statin or ezetimibe has not much effect on LPA value. So it is of no use. Exercise has no use on reducing LPA. So when the PCSK9 came, that was the first inclination when people thought that. Because even in the PCSK9 trial, it was seen that the residual risk, one of the reasons could be the elevated LPA. If you have more than 80 milligrams or nearly 100 milligrams, your risk goes more than 3 times, cardiovascular risk. So these were the times when people thought that, well, we can possibly reduce LPA. And we know that LPA promotes ASCVD and aortic valve calcific stenosis. There are very many mechanisms of that. I think this is not the right forum to talk about the mechanisms. But then we have also epidemiological data, like the Bogalusa study, the Copenhagen study, again, Mendelian studies. So very many studies attaches importance to LPA and ASCVD and calcific aortic loss. Currently, again, something like the triglyceride, we have two newer agents. Again, tongue twisting names. Now we have novel therapies, mostly two molecules, nucleic acid derived analog called pelacarsen. And we have a couple of trials with that, the LPA Horizon data. And pelacarsen reduced LPA by a whopping 80%. Never in the history of medicine we had such a tremendous amount of reduction in LPA. And we have another drug. We have a small interfering RNA. These are the times of small interfering RNA. You remember about inclisiran and how inclisiran is going to possibly stop all heart attacks in the near future. So in the same way, we have olpasiran, a small interfering RNA to reduce LPA, and that reduces LPA something like 76%. So olpasiran and pelacarsen are the two novel therapies which possibly, again, it will definitely need a lot of data, clinical data, outcome data, but these are agents which we are definitely looking at. One of the possible caveat it could be, there was a question posed in some of those studies, LPA studies, that does a very low LPA cause diabetes? I mean, something like we have been discussing about statin and diabetes, where we know it's a fact. But then when you compare the advantages of statin over the disadvantages of development diabetes, we know the advantages still prevail. So we don't know about the importance of LPA reducing agents and the advent of diabetes. We have better people in our endocrinologists who can advise us on that particular point. Thank you, sir, for your kind attention.
Thank you, Dr. P.P. Mohanan, for such an excellent presentation. Dr. Mohanan has told us two important facts. One, the importance of triglycerides. Two, importance of the LPLA, that is lipoprotein little a. And also he has told us about the newer molecules which are available for controlling these two risk factors. But I am sure he should have also told us about the importance of the lifestyle modification for the residual risk. I'm sure in the discussion he will tell us more about that. Now, we move on to the second speaker, and he is going to talk about second speaker. Yeah, he is going to talk about the real world hypoglycemia in older adults with diabetes. We all know that elderly diabetics have greater chance of going into hypoglycemia, especially because they do not take their food at the right time. And many of them take their medicines but skip the meals. And also there are so many other causes for increased hypoglycemia in the elderly population. And I'm sure my friend Dr. V. Srinagesh will tell us more about that. He's a very experienced endocrinologist. He is a consultant endocrinologist at Hyderabad. And Srinagesh has and endocrine clinic. And Dr. Y.R. Reddy, he has received Dr. Y.R. Reddy Gold Medal in January 2007 and S.V. Rao and M.M. Swami Medal for passing MD Part 2 in first attempt for the year 2007. He was adjudged the best orator at TISA meet for his presentation, and he is a fellow of 14-hour APES, ISPAD, and SP Science schools. He is a fellow of ESP Advanced Seminar on Endocrine Disruptors in Rome 2015. He is a fellow of the 24th EASD Scientist Training Course in IBAPS Barcelona. And he has received the Anil R. Sheth Award for the best paper in SCCon 2017. He has peer-reviewed 25 publications and he has got 15 textbook chapters. My dear friend, Dr. V. Srinagesh, I invite you to make your presentation Now the floor is yours. Thank you very much.
Thanks a lot, sir. Thanks for the introduction. And it's a pleasure to be back for the Corona Remedies meet again, where we'll be trying to integrate the recent ADA topics into the Indian scenario. And what I'm going to talk about for the next 15 minutes would be about real-world hypoglycemia, setting the context with an Indian setting. Over the last 20-25 years, we've actually seen that the geriatric population of the country is going up, and it is common knowledge to most of us that the diabetic population in India has been going up. We are now not only the world's most populous country, but for all practical purposes, we are also having the largest population of diabetes in the world. And the number of elderly people with diabetes in India is also increasing over a period of time. We don't have large-scale data about what actually constitutes the prevalence of diabetes. In fact, some studies, there was a Northeastern study which actually put the prevalence of people with diabetes at around more than 65 years at around 7.5%. Then there were some studies which actually very small studies which were done in isolated centers which put the number of people with diabetes over 75 years. The really elderly population at around 5%. Between 2018 to 20, we had a very large India-wide study which involved 72,000 respondents who visited various clinics. This was done both in an Indian setting, in a rural setting, as well as in an urban setting. And not surprisingly, they actually found out that the prevalence of diabetes in people who were older than 60 years of age was more than 60%, was more than 26% in over the age of 60 in urban setting, whereas it was around 10% in people who were in the rural setting. And this prevalence was maximal in the southern states, union territories, Punjab and Delhi, high in the northeastern countries, northeastern states, and slightly lower in central India, thus underlining that fact that hypoglycemia is very common in the Indian population. And as far as the treatment pattern for hypoglycemia is concerned, even today, because of the low cost, insulin and sulfonylureas remain the most commonly used medications for the management of diabetes. And this has become a huge cause of concern. Almost all of us who are involved in our day-to-day clinical practice do know that the first drug which is prescribed for a lot of people because of cost factors after metformin remains a sulfonylurea. Now that DPP-4 inhibitors and SGLT2 inhibitors have come off patent, we have slightly increased the use of these molecules, but again, tolerability is an issue. Appropriateness of this molecule is an issue, especially in postmenopausal women. And because of very high blood glucose levels initially at the time of first contact with the doctor, we tend to use more of sulfonylureas. And once people, and especially at the general practitioner level or at the physician level, use of premix insulin or use of combination therapy with sulfonylureas and metformin remains the commonest prescription even today. And sometimes this can extend to very high and very irrational doses of sulfonylureas, which is what constitutes a major risk in our general population. We don't have corresponding Indian data, but if you actually look at US data, they had a study called INFORM, where they recruited a lot of elderly people who were at risk of diabetes and who were predominantly either on sulfonylurea or insulin. And when they actually took down the data from these people, they found out that people who were on these two particular molecules tended to have a much greater risk of hypoglycemia. And this risk was more in people who were using the older sulfonylureas as opposed to the newer sulfonylureas like Limipride. And also people who were on basal insulins and also the second generation insulins and analogs tended to have almost 50% lesser hypoglycemia than people who were on the older generation analogs. To be very precise, people who were on the second generation of insulin like Glargine as opposed to people who were on NPH had 19% lesser risk of overall hypoglycemia and 43% lesser risk of nocturnal hypoglycemia. And it is this nocturnal hypoglycemia which actually contributes to cardiovascular events and mortality in this particular population. And the Golden study and the INFORM study actually said that we should be focusing more on piping down our use of sulfonylureas and insulin in elderly population. And at the same time, even if we are using these molecules in this population, we should be on the alert for hypoglycemia and try to use the newer molecules wherever cost is not a factor. Coming briefly, many people do not exactly have a clarity what constitutes hypoglycemia. We have had many definitions for hypoglycemia. Many of the pharma interventions have actually muddied our understanding of hypoglycemia. To give you a brief perspective of this, the minute your blood glucose level goes below 80 milligrams per deciliter, the first pathway in this is shut down, which is the secretion of insulin. Once your blood glucose level comes below 70 milligrams per deciliter, this is what constitutes true hypoglycemia. And that is where your counter-regulatory mechanisms step in. First, your glucagon is increased, then your adrenaline is increased, then subsequently cortisol is increased. But in a lot of people with type 1 diabetes, as well as in elderly people, insulin secretion is not always shut down, especially in people who are already on exogenous insulin or sulfonylureas, which are not within your control. You do not have glucagon secretion is shut off. A lot of people will not have counter-regulatory responses, and hypoglycemia unawareness becomes a major problem. Many people, once they are accustomed to long-term hypoglycemia, start developing less and less neuroglycemic symptoms, and this is what actually contributes to their unawareness and lack of understanding of what the fact that they are having a hypoglycemic episode. So with each hypoglycemic episode, the tolerance to hypoglycemia goes up, and they might not even report symptoms even when their blood glucose levels fall below 54 milligrams per deciliter or 3 millimoles per DL, which is what constitutes what is known as a severe hypoglycemia. In addition to that, what many physicians are not aware is what is known as a relative hypoglycemia. For somebody who has a blood glucose level of 300 milligrams per deciliter, starting them on a high dose of insulin or using a large dose of sulfonylurea can rapidly bring down their blood glucose levels to around 120 milligrams per deciliter in a day or two. This might seem normal to us, but for the human body, it is an absolute drop of almost 180 milligrams per deciliter in a day or two, which the body construes as hypoglycemia. And the body can very well present with all the symptoms of a hypoglycemia, can also present with all the consequences of a hypoglycemia, including cardiovascular events. And this is the reason why we don't need to rush into managing diabetes, be it to bring down the blood glucose levels or to impress the patient. We can take as much time as we want. The usual median time we give the patient for controlling hypoglycemia is 3 months. And wherever possible, we need to try to use agents which do not cause significant hypoglycemia. And this has been again underlined by a lot of trials. Whatever the trial might be it VADT, be it ACCORD, be it ADVANCE, in almost all these trials, wherever intensive hypoglycemia was used, the long-term outcomes were definitely better, but at the same time, this came at a cost. The relative risk of hypoglycemia definitely went up. And as was seen in ACCORD, even the all-cause mortality went up once these patients were started on more intensive regimens. In fact, the number of hypoglycemic episodes was almost 4 times higher in the control group, in the intensive care group, as opposed to the control group. 1.06 episodes of hypoglycemia per treatment period versus 0.29 episodes of hypoglycemia in the control group. And the risk of unrecognized hypoglycemia was also double in the people who were in the intensive group as opposed to the control group. And it was after this that people started focusing more on less stringent control in people who had diabetes and who were in the elderly age group to prevent cardiovascular mortality. In fact, if you look at the risk of hospitalization in elderly people with diabetes, more often than not, in any person who is hospitalized because of an adverse event with a diabetic agent, it will almost always be a hypoglycemic episode. Very rarely do you have falls or hyponatremia, which are commonly seen with SGLT2 inhibitors, or for that matter, severe gastritis. For all practical purpose, an elderly patient getting admitted for an adverse event with a diabetic agent implies hypoglycemia and nothing else. And this can add to the morbidity of the patient, can add to the mortality of the patient, and can also add to the subsequent cost of the patient. And most of these adverse events are because of 3 groups of drugs: sulfonylurea, insulin, and the glinides. And more often than not, a lot of major hypoglycemic events in patients tend to get underreported. What we are seeing as far as hypoglycemia is concerned is only the tip of the iceberg. More often than not, patients do not report their hypoglycemic events to us for a lot of reasons. Many a time, like I've already said, they have had chronic hypoglycemia. They are unaware of the fact that they have a hypoglycemia. They do not correlate this with hypoglycemia. As you grow older, you tend to have very non-specific symptoms as far as hypoglycemia are concerned. Many patients can just present with simple dizziness, can present with sweating. These can be because of a multitude of reasons. And not always attributed to hypoglycemia. So they think it's because of their diabetes, because of their age, or because of their cardiac medication. Many of them lack the knowledge that hypoglycemia can cause these kind of symptoms, and it is up to us to educate the patient. Many a time in our busy practice, we do not have time to educate our patient. It is always a very sensible measure to give the patient a handout, which tells them what exactly constitute the symptoms of hypoglycemia and what are the warning signs and what you should do if you have a hypoglycemia. Patients are, some of the older people are very apathetic towards hypoglycemia. It's become a part of their daily schedule for them, and they have become indifferent. In fact, even older people who drive do not commonly report hypoglycemia because they're afraid that their family members can bar them from driving. Loss of independence also becomes one of the major factors why people do not report hypoglycemia. These are all these reasons, both patient-related as well as doctor-related, which contribute to the risk of unreporting and underreporting of hypoglycemia. And if not recognized in time, this can lead to major adverse consequences for the patient. And it is an axiomatic fact that if you have had one hypoglycemic event, you are much more likely to have a second hypoglycemic event. And that is the reason why I always tell my patients to have a glucometer with them, carry the glucometer along with them wherever they go, and any time they develop a hypoglycemia, immediately record their blood glucose levels because they check their, before they take in remedial measures, because we have to have an idea of what is happening with their patient. As far as the single most important reason for hypoglycemia is concerned, it remains overtreatment. If you look at a bulk of treatment for the elderly population, you will see, not only see that they are being put on insulin and sulfonylurea, more often than not, you will find out that majority of them are being treated with 4 mg, 6 mg, 8 mg of even relatively safer drugs like sulfonylurea. So you have to understand that there is a law of diminishing returns operates when you are treating people with molecules like with sulfonylureas. The more you increase the dose, the less is the amount of return. I generally try not to go beyond 2 mg of sulfonylurea in a day. You can go up to 4 mg, but rationally in the elderly people, it's good clinical practice to either stick to 0.5 mg doses or 1 mg doses, or at best 2 mg. Even insulin doses have to be rational. People tend to forget what is known as the Soumitra phenomenon. An elderly person waking up with a headache and a very high blood glucose level in the morning does not always need an increase in his insulin level. What is required here is a continuous glucose monitoring or a measurement of the early morning blood glucose level to see whether he's had a hypoglycemia at around 3 to 4 a.m. in the morning, after which a hyperglycemia supervenes. This person will not require an increase in the blood glucose levels. He actually requires a decrease in the blood glucose levels. And interpretation of all this data will require a continuous glucose monitoring, not monitoring your blood glucose levels once every 2 months when the patient comes to the OP. And this is for this reason that we always have to educate a patient to keep checking his blood glucose levels with a glucometer. And it is not always fasting and post-breakfast glucose levels. You have 24 hours in a day. They also have to do a before lunch, before dinner, bedtime, once in a while early morning levels, or use a continuous glucose monitoring, though many of the current CGMS probes in the market are quite inaccurate when it comes to hypoglycemia. And this is where, coming to the last part of the talk and looking at the bigger picture, we need system level interventions. Whatever I have told you now are something which is done at the individual level care. But what we have now is what is known as a system level intervention. And the need for system level intervention has become very acute in the US of late because of insurance pressures and increasing corporatization, which has already happened in India, is now happening in the US. Doctors are unable to give more time to the patients. They are not able to focus on the relevant aspects of care for the patient. The second part is the insurance system in the US actually rewards patients who have lesser HbA1cs. This has actually resulted in more and more targeted therapies towards lowering the HbA1c with very less regard to safety. So while rewarding patients for good clinical practices and good health practices needs to be encouraged, there has to be a limit to this. And an HbA1c of 7 should not always be the target. In fact, if you look at the recent American Geriatric Association guidelines, and if you look at their Beers criteria, they have come down to some extent on SGLT2 inhibitors. They have added a caution to SGLT2 inhibitors because of risk of euglycemic ketoacidosis. Caution about insulin and sulfonylureas has always been a part of the picture because of risk of hypoglycemia. And they have actually focused more on keeping the HbA1c cutoffs at around 7.5 in the elderly population, especially people with a life expectancy of not more than 10 to 15 years, who have cognitive dysfunction, who are bedridden, or who have diabetic comorbidities. In all these patients, it makes sense to have slightly lesser stringent glycemic targets so that we don't overtreat the patient. At the same time, we don't relax it so much that they end up with diabetic microvascular complications. And of course, the most important part, and which is not always in our hands, is the cost of therapy. The single most important reason why we use sulfonylureas and insulin in the management of diabetes is because they are the cheapest medicines. They've been around for a very long time. If you look at recombinant insulins, they cost you very low. 200 rupees per vial is what would be the lowest cost for recombinant insulin. Sulfonylureas are available for as low as 1 or 2 rupees in a day. And this essentially leads to a tendency where we tend to overtreat people with this molecule rather than going on to the slightly more expensive molecules. But now that India has reached a stage where rightly or wrongly, we have taken the patent of a lot of medicines. We have forced patents of a lot of medicines. It has made more expensive medicines affordable to our patients. And it is time we started taking advantage of this particular facilities which have been provided to us so that we treat patients with more effective medications. I don't say that we should stop the use of sulfonylureas, but we should limit and rationalize the use of sulfonylureas. Wherever possible, try to use a basal insulin rather than using a premix insulin, or convince the patient, talk to the patient and split your insulin into multiple daily injection regimen rather than using two very large doses of insulin, split it into 4 smaller, more rational doses of insulin in a day. And this is where US has actually come up with what is known as the Choose Wisely Hypoglycemia Prevention Initiative. This has been started as a pilot project in a few hospitals where they actually pick up the patients who are visiting their OP who are at risk of hypoglycemia. The next time the patient comes to the OP, an alert is generated in the system. A questionnaire, a very small questionnaire is given to the patients about the risk of hypoglycemia. Their responses are recorded. And if it is understood that the patient is having a hypoglycemia or has had an hypoglycemic episode and has not reported it, then an immediate decision is taken to dial down on the treatment. This is recorded in the EMR, and this template is developed further so that it can be applied to further people. This has already been completed and is now about to take off in a big way in the national setup. And I think this kind of initiative also needs to be taken up in India. And people like Sanjay Bhadada sir, who are at the vanguard of healthcare in the government sector, should need to do more of this, should be the people who should be taking up the onus of taking up these kind of initiatives in India, because overtreatment is as much as a problem in India as it is in the US. To conclude, the only thing I would say about prevention of hypoglycemia in the Indian population is, one, from a practice setup, what we as doctors can do. We need to increase patient engagement. We need to specifically ask patient whether they've had a hypoglycemic episode. Ask them whether for the specific symptoms of hypoglycemia. Tell them what they have to do. Educate them properly about insulin injection techniques and proper use of insulin. Slightly dial down on the doses of sulfonylurea and hypoglycemia, and educate them. The easiest way of doing it is giving them a paper pamphlet or a paper sheet about the risks of hypoglycemia, symptoms of hypoglycemia, and what to do if you have a hypoglycemia. Most of our patients actually tell us, I had a hypoglycemia and I took a chocolate and I felt better. This is not how you deal with hypoglycemia. You have to take 15 grams of glucose, recheck your blood glucose after 20 minutes. If it is still low, you have to increase your, you have to again take a second dose of glucose or sugar. This is the ideal method, and we have to make sure that every patient who visits our clinic and who's at risk of hypoglycemia is aware of this practice. Wherever possible, we need to ramp up diabetic education wherever financial matters permit. Give them, make some YouTube videos regarding this, give them some pamphlets, or even put them in touch with resources or patient groups which can educate them better, or just give them access to some website like the ADA or the Endocrine Society, which has made up a lot of recent pamphlets about hypoglycemia and risks of diabetes so that they can read for themselves. But the biggest change does have to come from the policy department. One, the pricing of other molecules need to be brought on par with sulfonylureas and insulin so that these molecules do not automatically become the first choice, even in elderly patients. Many of the elderly patients are financially constrained, and by default, we have to use them. We have to put them on insulin or sulfonylureas. Even a lot of times, even people who are living alone, who are very poorly controlled, need to be put on insulin because of these cost factors or poor glycemic control factors. And this is where policy changes do come in. And the other place where we can actually use this is technology, use of better and more reliable glucometers. We now have cheaper glucometers, but as to how reliable they are is still a matter of debate. What we need to do at the policy level is make cheaper glucometers available to the patients, and most important, make sure that the glucometer strips which are available to the patients are reasonably cheap. Patients should be educated about easily disposing them, and the fears patients have about checking with glucometers need to be allayed. And wherever possible, continuous glucose monitoring should be utilized in a rational, effective, and an economical manner. And we always have to educate our patients that whenever you get a hypoglycemia which is recorded on a CGMS, please corroborate it with a glucometer level, because CGMS is not always reliable in people with CKD who are at huge target risk for hypoglycemia, as well as in people with hypoglycemia where CGMS might not always be the most accurate method of recording a hypoglycemia. So if you only initiate changes at the patient level, at the physician level, as well as the government or the national policy decision-making level, are we going to make a dent in this huge risk of hypoglycemia, which is a clear and present danger even today in the management of diabetes? Thank you, and over to the chairperson, sir.
Thank you, Dr. V. Srinagesh, for the excellent presentation. I congratulate you for making it as simple as possible. He has told us the costs of real hypoglycemia and how to manage hypoglycemia, and also the importance of the newer insulins compared to the older insulins. And so we have learned a lot of things, and we will have more discussion later on. Now we go to the third speaker. The topic is, do we address the psychosocial determinants of health in diabetes and kidney disease? I know that this is not very often discussed, neither do the physicians know much about it. And as you know, long-standing diabetes leads to depression, and the kidney disease, people have depression, and in addition, they are anxious. And I am sure Dr. Avinash Ignatius, MD, DM Nephrology, is a senior consultant nephrologist, transplant physician, and head of the Department of Nephrology, Noble Hospital, Pune. He is MD in General Medicine from St. John's Medical College, Bangalore. DM Nephrology from All India Institute of Medical Sciences, New Delhi. He is a senior consultant nephrologist with nearly 2 decades of experience in the field. He heads the Department of Nephrology and Renal Transplant at Noble Hospital, one of the largest units with 27 maintenance dialysis stations. He is a founder member of the Indian Society of Nephrology, Pune branch, member of the Indian Society of Nephrology, Indian Society of Organ Transplant, and Association and International Society of Nephrology. He has authored 3 book chapters. He is a principal investigator, national and multinational clinical research trials, phase 2 and phase 3, involving innovative new drugs, including recent Olympus, Rockies, DAPA CKD, FIND CKD trials. Now, Dr. Avinash Ignatius, I have immense pleasure to invite you to make the presentation. Now the floor is yours. Thank you.
At the outset, thank you very much for the kind introduction, sir. And a pleasure to be here on this Sunday afternoon in this interesting session with such eminent speakers here. So moving away from the topics predominantly on treatment, this is something, as said, it's something, a topic which you often don't focus on, or really don't have that much time to focus in our busy practice with so many patients lined up. But it's a very important factor in the way a person perceives the diagnosis of CKD or kidney disease when he's a diabetic. And if we see, there are a lot of ways a patient comes across. Some may start with just a proteinuria or a microalbuminuria and then get referred to a nephrologist. A patient may have early chronic kidney disease, probably chronic kidney disease stage 3, creatinine has just started going up at a level of probably 1.5 to, or some patient comes at a more advanced chronic kidney disease, maybe at a stage when his creatinine is reaching 4 or 5 and he's almost nearly CKD 5. So the way a patient perceives is a lot of ways related to his socio-cultural background, his own personality, and what he has preconceived notions about kidney disease. And a lot of it is actually affected by the background. So a lot of times when the initial diagnosis of chronic kidney disease comes, the first initial approach is, do I really have it? There is a lot of denial in patients at this particular stage. The denial is not very strong in the initial stages because the creatinine appears to be just a little bit elevated, although most of the time patient don't realize that this elevation of creatinine reflects a significant drop in GFR, where creatinine starts going up only after we have lost about 50% of GFR. They sometimes think that probably the reports are wrong, or maybe they want to check on go to another doctor or go to another lab. So a lot of time this denial goes on for a few weeks to months before they accept that yes, there is a certain problem with their kidneys. And then the next stage is having an anger. So the anger may be just on the situation where he's someone who has been a diabetic for a long time, already has been taking a lot of medications. And on top of that, when they get diagnosed with a chronic kidney disease, they also may get diagnosed with hypertension. They may have coexisting cardiovascular disease. They may be already on a lot of pills which have been already taking and have been affecting his overall lifestyle. And having an additional add-on of a kidney disease can create a lot of anger, which may be directed certainly sometimes to the physician who is practicing itself, not because he blames him. It is just that his outlet on that frustration is probably towards the physician. It can be towards the family members. It's just directed towards the younger members in the family or the spouse. And this anger, again, can take a varied amount of time to resolve depending on the personality and level of the way the person deals with these issues. So many times this effect of chronic kidney disease directly, the moment a person is told that you need to see a kidney specialist or have a kidney problem, the first thing which comes to their mind is that they start thinking about dialysis, not realizing that dialysis is the last stage, and it is not that anyone who has kidney disease has to go for dialysis. So a lot of myths and preconceived notions which are prevalent in society, they lead to incorrect perceptions and fears, and this particular fear can continuously affect them, not just when they visit us, but this overbearing thought about their outcome, their life, their quality of life can affect their mood at home. It can affect their mood at workplace, their ability to focus and get effective result in their workplace also might get affected. So this all pervasive low mood can overall affect their quality of life. And the most feared thing is about dialysis. The moment patient knows that he has got chronic kidney disease, his family, they all develop a fear that when is this particular person going on to dialysis. So this all pervasive fear, sometimes anger, denial, low mood, all this can cause a significant effect on the quality of life and his engagement in other activities of living, and bring down the overall pleasure of having a good quality of life. So there are a number of factors which can affect the way a person perceives this, and it really varies from person to person. It also varies from the age. We have a lot of young people who are now getting diabetics at younger years. Our previous speaker quite clearly highlighted us becoming the capital of diabetes of the world, and along with getting the capital of diabetes of the world, and the younger and younger population are getting affected, and a lot of them come to us with a presence of chronic kidney disease in their 30s, 40s, and it is one of the most productive periods of their life. So this can itself, if a young person is getting affected, that there is a there's a strong denial at why I should be suffering at this age, while his peers are probably doing everything. And once the diagnosis comes, already there has been certain dietary changes which have been advised because of his underlying diabetes. And the moment chronic kidney disease comes in, there are many more other dietary restrictions which come in. So that again is a factor which adds on to the person's depression, their ability to adjust. And because the person's adjustment requires also the family to adjust, there is not just an effect on the patient, but that also goes on to affect the family members, the persons who are responsible for his food at home. And a lot of times, young people who are working from morning to evening may not have access to the kind of food they require. The kind of foods provided in many of the places where they're employed can have a significant effect on what they eat, how they eat, and whether they're having adequate food intake. Having another chronic illness can affect their self-esteem, the feeling of inadequacy, the feeling that they are not equal to others, the feeling that they may not be able to perform as well as what others are performing because of these coexisting problems can affect their self-esteem. Sleep is affected both maybe because of medicines, maybe because of dyspepsia, maybe because of anxiety and depression. So it can be a significant factor in their overall outcome. A thing which is not often discussed and neither the patients often come out is about sexual dysfunction, which already may exist because of diabetes or may get worsened with chronic kidney disease on top of that, or coexisting medications. So that is something which we need to remember and probably ask proactively to a patient, which might be sometimes a major cause of depression and sleep issues in these patients. Now, the topic which we were discussing both is psychosocial, because a lot of psychology is also affected from the way the person comes into, in what kind of social background he is from. And there are a lot of social factors which affect the way a person perceives. So one is economic stability, or the way the person's economic status is. And we all know the cost of medical care is prohibitive for a lot of patients from certain socioeconomic backgrounds. So they are worried about their job security, especially if a person leads to end-stage renal disease and has to go on to dialysis. The thought of coming thrice a week for dialysis, whether he can afford that, whether he can spare the time, these become an issue. Then there are environmental factors. All persons may not work in office. Some people may be working in areas which are industrial areas which may not have climate control. The heat may be significant. They may sweat a lot, but from chronic kidney point of view, they may have to restrict a lot of fluids. So where the person works, the kind of housing conditions, do they have proper access to, in the way the climate change today is in severe heat, do they have access to cooling, or in cold places, do they have reasonably good access to temperature controlled environments? Is it there? Those affect a person's outcome. Education has a significant effect. Well-educated people may understand the science behind our treatment better, but again, a person who is not well-educated or is not able to perceive the science behind things are more likely to get diverted to a lot of other cultural beliefs which are prevalent, or go on to therapies of medicines which are promoted online, which may not have any scientific basis and may be harmful actually to that patient. So all these things significantly affect the outcome of a patient. Presence of health coverage. Is the patient insured? Does he have any coverage under a government scheme or his own insurance, or is paying out of pocket? So these are significant factors which can affect the outcome for CKD or diabetic patients. And just coming towards the end, we need to remember that these psychosocial issues remain in the background, and unless we proactively ask, a lot of time these things don't come ahead unless there is enough time to spend with the patients. And these factors can influence the compliance of the patient, the outcome in this treatment, and overall affect the patient's quality of life. So with this, I will end my talk, and then we can go ahead and see in our discussion what comments are there. Thank you, sir.
Thank you, Dr. Avinash Ignatius. It has been a good presentation, and we are all very happy about that. In addition to depression and anxiety, you told us about the importance of anger in many patients with chronic kidney disease. and also how to manage both anger and also sexual dysfunction. Now the topic is open for discussion, and I will start with Dr. P.P. Mohanan, and he has told us very much about LPLA and triglycerides and other residual risk factors and how to manage. Of course, this topic was new treatment possibilities. Maybe it was a reason why he did not mention about lifestyle modification, which is very, very important in the management of residual risk factors. And I want Dr. Mohan to tell us more about the possibility of lifestyle modifications in our society. Mohan, please.
Thank you, sir. I mean, no questions asked about the importance of lifestyle improvements. I mean, I was asked to talk on the pharmacological approach of, but then, as you rightly said, we have a favorable lifestyle definitely lowers coronary artery disease by 44% of the over the next 10 years. And if you take the average incidence of a 10-year cumulative rise of CAD, that'll be 40%. So lifestyle has tremendous influence on development of coronary artery disease and also development of diabetes. There are very many studies which have shown that up to 67% decrease in the development of diabetes could be there when you approach, when you accept, when you concentrate on your diet, your physical activity, your cessation of smoking. So, I mean, no questions asked about the relevance, and that too in a country like ours, which is a poor or lower middle income country, where all those exotic fancy drugs that I mentioned are not in the purview of many of the population. So no questions asked about, sir. Lifestyle modification, a favorable lifestyle matters. Your diet matters, your exercise matters. And if you can get something like a 600 minutes in a week, I think that will be one of the aspirations that we should be providing to every patient with diabetes.
600 minutes.
And
600 minutes.
Yeah, 600 minutes per minute. Basically, it is 30 minutes every day for at least 5 days. And the next 2 days, you do some resistance training. That is the current recommendation. But, or if the WHO want to quote the WHO, they will say 10,000 steps per day. But then we have also evidence that even if you cross 7,000 steps a day, that is suffice.
Thank you.
Well, we now move on to Dr. V. Srinagesh. And as you have said about the real world hypoglycemia, I would like you to tell us exactly what is the percentage of patients who go into hypoglycemia with the commonly used drugs, and which drug would you choose if you are given a chance to prevent hypoglycemia? Dr. Nagesh, please.
Sir, if you are on insulin or a sulfonylurea,
I'm on nothing.
Have one episode of hypoglycemia. One way of looking at it is you are going to have one episode of hypoglycemia if you are on either of these two drugs in your lifetime, at least one episode. If you are on the other drug, as far as real world data is concerned, like I've already told you, almost 85% of our patients don't report their hypoglycemic episodes, but it is quite common. Many studies have actually told us that the prevalence of hypoglycemia is somewhere to the tune of 20 to 30% of people who have therapy for diabetes. And if I had an option, my first option always remains metformin, but many of our patients do actually come in with higher HbA1cs. My preferred second line molecule, in spite of the current ADA evidence, does remain a DPP-4 inhibitor because of the ease of use of DPP-4 inhibitor and the fact that the number of elderly people in our practice is increasing day by day. We have a setting where we can safely use an SGLT2 inhibitor. I would use an SGLT2 inhibitor. And I definitely do use sulfonylureas, but I use very low doses of sulfonylureas. I generally, almost as a rule, never cross 2 mg. I would prefer to keep it at 1 mg per day. I use glimepiride, rarely glipizide. And Pioglitazone also has some role. GLP-1 receptor agonists, in my practice, it's very limited because of the cost factors. Now that liraglutide is going off patent, perhaps it might become more common. And insulin, I do use a lot of insulin, but I use basal insulin. And I start with low doses of insulin because I go by what was seen in the Atlanta study. This was one of the recent studies which started with Glargine. They started with doses as low as 5 to 6 units per day. Ask the patient to self-titrate, check the blood glucose levels to reach a target of 120 and increase your insulin levels by 2 units every 3 days. This seems to be a very sensible approach for the management of hypoglycemia, especially fasting hypoglycemia and early diabetes. When you are forced to use insulin, start with a low dose, escalate every 3 days. When you hit 120, freeze the dose, go below 100, cut down the dose. This is what I generally tend to do and have very low hypoglycemias with this kind of dosing. But if you start with higher doses as given in the recommendations, 0.3, 0.4 units per kg per day, you have to understand that most of these recommendations where they have given you this kind of 0.3, 0.4, 0.6, 0.8 units per day was with the assumption that you were not on the other medicines. And when these recommendations were given 20 years ago, you did not have potent medicines like SGLT2 inhibitors or GLP-1 receptor agonists. So I think we actually do need to have a rethink about our current insulin recommendations. The doses need to be lower, both for insulin as well as sulfonylurea. Does this answer your question, sir?
Yeah, thank you very much. It's been very nice. And then now we move on to Dr. Avinash.
Yeah, I have a comment here in addition to that. Dr.
Please
Nagesh
do.
has covered very nicely. Sometimes we do see patients are having hypoglycemia because they are prescribed the drug other than what is actually meant for that. So that is another important thing for our understanding and for our knowledge, that when we write prescription, the spelling is not correctly mentioned. Sometimes patient get the different drug, even patient is not having diabetes also. So that is number of drugs are available with the similar name. So that is another thing we should keep in mind in addition to what Dr. Nagesh told. And then we can use the sulfonylureas, those are less potent, or you can say there's less hypoglycemic agents. And maybe in special situation like in patient with CKD or elderly patients, especially you can use the short-acting sulfonylurea like glipizide or the gliclazide, etc. Thank you.
Sir, if I might like to add one point to what Sanjay Bhadada sir has said. Drug substitution, especially by a lot of pharmacies, has now become a major problem, sir. A lot of times, I've seen prescriptions where I give the patient sitagliptin and he's actually told that vildagliptin and sitagliptin are the same, or you give somebody glimepiride and he's given glipizide.
Yes.
This kind of unrestricted drug substitution, I think we need to have a law about this. Or if there is a law, it needs to be enforced more carefully.
Yeah, that is now another problem now, because you prescribe, they are asking to write the generic drug, something like that. And now the pharmacist is doing their wish rather than anything. So that is another problem which is creeping in. Yeah. Thank you, sir.
Thank you. Now, Dr. Avinash, you have told us about the psychosocial factors in patients with diabetes, with patients with kidney disease. And you have emphasized on the importance of sexual dysfunction, which many people may not disclose to you, and only on direct questioning they will tell you. Now, if somebody comes with sexual dysfunction, what is the type of advice you give to them and how do you manage them? Please make it clear for the benefit of the younger generation.
So, considering that sexual dysfunction can be quite frequent and is significant, one is to proactively approach and ask the patient once. Sometimes they may not be, there are 4 or 5 family members, they may not even be open about it. So we need to kind of inquire in a subtle manner. The first thing we look at is whether he is well controlled on his sugar point of view. The primary to look whether his sugars are well controlled in the last few months. And if not, we probably ask him to review with his diabetologist to get his sugars optimized. Second, certain medicines can also contribute, especially beta blockers may be there, which may, in addition to contribute to erectile dysfunction. And address that and see if that helps improve his sexual dysfunction. Third, if patients are in advanced renal failure, sometimes uremia, or patients who are on dialysis who are not getting adequately dialyzed, they themselves may be, that itself may be a reason for a person to have maybe depression or erectile dysfunction. And erectile dysfunction may be also a part of severe depression. We
That's
rule
right.
out
Do you advocate
these
pudendal
treatable causes,
artery
and if
stenting?
none of these are probably appropriate, I think that is something which comes much later, sir. And I would probably recommend a urology review before I would recommend something to that, because I am really not too conversant with the procedure. So I may not be the right person to answer on that now.
Yeah, there are some centers in India where they are doing pudendal artery stenting for erectile dysfunction, and some of them have given good results. Because as you know, the coronary arteries and the pudendal arteries are more or less of the same size, 2 millimeters. So when the coronary artery gets narrowed, where the coronary artery lesions occur, more or less the similar lesions occur in the pudendal artery. And that is responsible for the erectile dysfunction. And if you can open up the pudendal artery, it may help some people.
Yeah, I agree with you, sir. And there is a lot of now the therapeutic armamentarium for the ED is very wide. The only question is that people are not coming forward with their complaint, or instead of talking to a doctor, they are going to quake for this type of treatment. Yes, so it is the treatment is available in various ways, and it is really effective. And especially in type 2 diabetes, the treatment is little different. Like if you use the what you call PD4 inhibitors, then they should be given 2-3 hours prior to the act actually. And another important, the dose is also higher in type 2 diabetes as compared to the non-diabetic individual. So this is indeed a lot area to discuss. There is itself is and not only this is for the males, but it is females are also suffering from this sexual problems in patients with type 2 diabetes. So we never dare to ask a lady that what is she satisfied, is any problem or not. So that is it altogether a missed area.
Thank you, Dr. Sanjay. Now I wish to tell you the story of a patient who came to see me this month. A 36-year-old female, diabetic and hypertensive for 4 years, had NSTEMI, was hospitalized in a good hospital. She had an angiogram which showed 80% lesion in the left circumflex and 50% lesion in LAD. She had a stent to the circumflex. She went home, came back to the same hospital with NSTEMI after 6 weeks. They advised angiogram, but she refused. And she went to the hospital adjacent to that and had an angiogram which showed 90% ISR in the stent. They did PTCI, put another stent and sent her home. And within about 2 months, she was hospitalized again in the same hospital with NSTEMI. They did an angiogram again, which showed 95% ISR and multiple lesions in other blood vessels.
Mm-hmm.
They did another stenting. So she had already 3 stentings and 3 angiograms. She went home. After a month, she developed severe angina, including rest angina. She went to a 3rd hospital. They did angiogram, and which showed 50% lesion in the left main, and then multiple lesions in the other 3 blood vessels, triple vessel disease with the left main. She was advised bypass surgery. All this happening within 8 months, 4 angiograms, 3 angioplasties, and after that, she is being advised for bypass surgery. She came to me about 15 days ago, and I told her that she can come for my treatment. therapeutic lifestyle change and optimal medical treatment. She was not receiving optimal medical treatment. She was overweight. Her BMI was over 29. And so she came in. Within 10 days, she lost 5 kilograms. And she was asymptomatic from day 3. And we did not do an angiogram. We did not do a treadmill test before the treatment because she had rest pain. And after the 10 days treatment, on the treadmill, modified Bruce protocol, she went for 15 minutes without any pain. And she was taking 2 types of diabetes medicines before coming to our hospital. And she went home without any medicines for diabetes. With the regular exercise, yoga, and weight reduction of 5 kilograms, her diabetes disappeared. She became normal. This is the story of a young lady, and this will go for presentation soon.
Yeah. So she need very close follow-up so that she can maintain and also.
Yeah, she'll come back to me after about a month. Now she has gone. She'll be back.
Ask her to monitor her blood glucose regularly.
Yeah, this is what I consider as iatrogenic malignant atherosclerosis. Because atherosclerosis normally takes 50 to 60 years to produce a significant lesion. But here, after the angioplasty and angiograms, multiple lesions occur and it goes up to 80%, 90% within 6 months. So that is a malignant process. So I term it as iatrogenic malignant atherosclerosis. I published it in one of the preventive cardiology magazines.
Thank you.
Any other questions? Anything else to be discussed? Please. Anyone wants to speak?
Yeah.
Otherwise, it is over to you, Dr. Sanjay.
Yeah, thank you, sir, for nicely conducting this program. And we have an interesting question answer session, and we had a wonderful 3 talks by all the expert speakers. And I think the original time was 12:45, and it's already, I think, 1 o'clock, so time is over. So thank you very much, the Corona Remedies, all the speakers, all the moderators for conducting such wonderful program was there on Sunday. And with that, I hand over the mics to organizers to take the proceedings further.
Okay. Yeah. Good afternoon, sir.
Good afternoon.
And on behalf of Corona Remedies, I really thank each one of you, especially to our post director, Sir Bhadada, sir, and all 3 eminent moderators, sirs, and all the speakers who take active participation and ensure the success of this Deciphering ADA with the concept of discussing the topic of ADA in Indian perspective, and all the delegates who actively participate. As we have seen that there are more than 1,000 doctors have spared their valuable time on Sunday and making this program successful. So on behalf of Corona Remedies, we heartily thankful to you. And the one part I would like to share, we at Corona believe in world-class quality from the international plants and with affordable medicines. That is our more motive, to make available medicines to more and more patients. And thank you for taking this science to the level next. Thank you, sir, on this behalf of Corona Remedies. Thank you for your active participation, sir. And with this, thank you, sir, for your kind presence.
Goodbye.
Thank you, sir.
Thank you, sir.